Good evening, doctors. A warm welcome on behalf of Shield Healthcare. I am Dr. Prachi from Shield Healthcare and I welcome you all. Today, yet again, we are bringing a new episode from TASK series, that is A to Z TASK series. So today's episode is W and it is brought to you by AGOG, which is Academy of Global Obstetrics and Gynecology. So let us have a short video on AGOG followed by prayer. Next slide.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
I'm very happy and honored to introduce today's coordinator, Dr. Anisha Datta Ma'am. Ma'am is Senior Resident, All India Institute of Medical Sciences, Kalyani, West Bengal, and had numerous academic achievements. Winner of Srimati Krishna Nadda Memorial Award in AICC RCOG 2019. Mrs. Indumati Zaveri Prize in AICOG 2020. Second Best Oral Paper in Milan 2022. First prize in FOXI South Zonal Conference with UR 2023 for Best Paper Presentation. Organizing Committee Member of AICOG 2023, and she was invited in various national and international conferences as a guest lecturer. So I welcome you, ma'am, and thank you very much for joining this webinar. And I hand over this session to you. So over to you, ma'am. Thank you.
Thank you, Dr. Prachi. Am I audible?
Yes, ma'am.
So very good evening to all the esteemed faculties. It's an honor for me as well for being a coordinator of this Trending Ask series. Our episode today is of W, that is when, what, and why we'll be discussing about this. And to begin with, I would like to introduce the very dynamic couple come convener and co-conveners of this TASK series, Dr. Komal Chavan and Dr. Niranjan Chavan. Dr. Komal Chavan is a medical director of Chavan Maternity and Nursing Home. She's a senior consultant in and unit chief in V.N. Desai Hospital, Mumbai, a chairperson of FOXI Medical Disorders and Pregnancy Committee 2019 to 2022, zonal coordinator for FOXI 2022 to 2023.
Thank you, Anisha. You can go ahead. You can introduce.
Yeah. Dr. Niranjan Chavan, our co-convener, is a professor and unit chief of LTMMC and Sion Hospital, joint treasurer of FOXI, president MOGS, member of Oncology Committee, Suffolk, and Joint Secretary of AG. And ladies and gentlemen, please don't forget, we have a very dynamic West Zone Vice President contest elections, and ma'am is a very suitable candidate for that. So we'll obviously not forget that in introducing her. And ma'am, I would request you to please begin introducing our chief guest and guest of honor.
Yes, thank you. Thank you so much, Anisha, for being the coordinator and the lovely introduction. And I welcome all of you for this episode W of Trending Ask the Expert series. And so many things. That is, we think about when to do, what to do, why this happens. You know, all these questions keeps in our mind. And we have chosen some few trending topics related to OBGYN in this subjects. And I'm very happy that we have concluded almost the A2W. Now we have almost reached, and we're just final end of our series. Has been a very great series, which is loved and liked by so many viewers all across India and even worldwide. And I'm so happy that today we have two eminent, one guest of chief guest and one guest of honor. And I take proud privilege to call upon Dr. Mahesh Desai. He is an academician, teacher, motivator and inspiring public speakers. And when I talk about Pankaj Desai, sir, you know what happens is that I read his posts. They are so inspiring. They are so good. You know, the humor, the pun in it, and it is really great to know such a personality. I'm just sorry about the word. My son is just keeping on calling me for no reason. So I'm just cutting his call. But definitely, I'm telling you that I'm so honored that Pankaj Desai, sir, is here today. He's consultant OBGYN specialist at Janani Maternity Hospital, Baroda. Former Dean and Professor Unit Head, Medical College, Baroda. He's received a lot of gold medal orations and so many guest lectures, authored books, a true academician. And I think the awards just adds to his CV. He's much more than what we all know. So over to you, Dr. Pankaj Desai, sir, to address the audience. We are all eagerly waiting to hear from you.
Thank you. Thank you so much. Honorable Dr. Komal Chauhan, Honorable Dr. Niranjan Chauhan, the guest of honor for this evening, Dr. Lakshmi, and the coordinator, Dr. Datta. From Kalyani, we know only Dattas, and friends, colleagues, ladies and gentlemen. I wish Komal all the best in her endeavor, and I'm sure she will not go to Foxy office as someone who came to run Foxy. बहुत आते हैं ऐसे और चले जाते हैं president, vice president. She will go to change Foxy. And that is a big challenge. It might need even later on fight in Supreme Court. Don't worry. Satyamev Jayate is not written only in our constitution. It is written in Mandukya Upanishad. Truth will prevail, whatever be the challenges. Dr. Chauhan, I told you in Calcutta, I'm telling you again, go to change Foxy. Don't go to just run Foxy. Hundreds are coming and changing every year. Go to change Foxy. Don't just run Foxy. Okay, that's the all. Your victory is 100%. That we will not discuss. I am talking one step beyond. Now, coming to today's evening. Since Corona, we have to officiate, of course, give lectures also and all. I've given orations here through the net. And as chief guest and guest of honor, I have decided not to do a routine blah, 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 blah. No, I will tell a story. My age is that of a grandfather, and what do grandfathers do? My grandma and grandpapa they told me stories. So I love to tell stories, and I tell stories which are based on true happenings. I tell stories which have actually happened, but I hide behind. Today I'm not going to hide much, but usually I hide the people who are mainly involved in it. Today there is no message in the story. There is nothing to carry home, but there is a stark, ruthless reality which will stir you up. There are certain things which just stir you up, and just enjoy that feeling. This happened in my medical college hospital. She was rushed down to the obstetric emergency rooms with advanced pregnancy, increased blood pressure, and heavy bleeding. Almost immediately she delivered. Her child was stillborn. All of your experienced obstetricians, those who are not ashamed to call themselves obstetricians, are also there. I can see their names. You know this is accidental hemorrhage. But it did not stop at that. Because of the raised blood pressure and bleeding for a long time before she could reach the hospital, her kidneys failed. We know that the kidneys dry up in accidental hemorrhage because of differential recirculation of blood, redistribution of blood. This is indeed a bad condition to have. Thankfully, biopsy showed that her kidney failure appeared to be of a type where recovery was possible. But in the meantime, she needed dialysis. Still, her system takes over. As luck would have it, all 3 dialysis units in the hospital were dysfunctional or were busy. So she had to be shifted to another government hospital, larger, in the bigger city close by, around 100 kilometers away. Obviously, she was in no position to spend for her transport, but the hospital had the facility to transfer her in free in ambulance. So the main part of dialysis at that government hospital was free. Each cycle of dialysis would still be costing her nearly 2,000 to 3,000 rupees for the disposables. Even if conservative expectation of around 5 to 6, 7 cycles were there, the cost would not be less than 20,000 rupees. The referring doctor medical team knew this. They sent one junior resident doctor in the ambulance. The unit had a pool of benevolent fund, absolutely voluntary, with contributions from all the doctors. They used to give, and it used to be there for such eventualities. Stuffing the resident doctor's pocket with about 25,000 rupees cash to be handed over to the doctor on duty at the kidney hospital, he was sent as an escort. He was given a clear instruction not to reveal to the patient from where their assistance has come. All was arranged and was going well. We got the news that she is recovering, and we were all happy about it. After some time, I had an opportunity to go to that city for some academic engagement. She was still in the hospital. Out of concern and wanting to make the patient feel cared for, I visited the hospital to meet her and her relatives. In a typical Indian tradition, she and her husband folded her hands in namaskar, and she had a smile on her face. She was obviously looking frail, recovering from such a major sickness and challenge. But what intrigued me was that her husband looked haggard and weak. Now, he was not supposed to be sick. He had not delivered. He had not recovered from a renal failure. They were obviously happy at her recovery and had all blessings for both the hospitals. But the look on the husband, all worn out and hungry, was disturbing me. There is something missing. And you all are doctors here, you know that a good doctor does not necessarily mean a good human being, but a good human being necessarily means a good doctor. Therefore, try to be a good human being. A good doctor will automatically follow. And so, I tried for this. I strive for this. Whether I have become is for destiny to decide or God to decide. On my way out, I took the husband with me out of the hospital ward, and inquired about her well-being and his well-being. What is the matter? Are you okay? Sagla bara hai ka? Tumi bhalo? In word of Anisha Datta. I asked. Everything is okay, sir. He replied with a forced smile. I was not convinced. What is the matter? Kai jhala hai? Kai problem kaya hai? Your wife is recovering now. She has been treated very well. Everything seems to be good to me. This is a negative way you talk sometimes to bring out the truth. Yes, sir. He sighed. All did not seem to be well. That is, yes, sir. I persisted. I wanted to know what was paining this man. Finally, he said, with folded hands, Sir, I am here in a totally unknown city. આ શહેર મારે માટે જાણીતું નથી. This city is not known to me. My wife has been admitted for last 10 days. In these 10 days, I have not earned a single rupee. As such, At our village also, I work as a laborer, sir, in the farm, in the field, with a near hand-to-mouth existence. Whatever my wife can help, we both work. Whatever little money I had brought from there, that could pull me on for 5, 6 days. Now, sir, all the money is over. I am not able to get enough food. I go to sleep in the hospital corner, at least they are allowing me this. But, sir, food. My wife gets her hospital bag. She shared something with me. Since then, however, that is not enough. Sir, that is the only problem. Lest all is well. And again, the typical forced smile came on his face. There is some organization. I put in a clue because I knew in that hospital, there was an organization like this, like in my medical college, which was providing food to the relatives. But sir, for the first few days, I could not get the needed identity from the sister in charge of the ward because she was on leave. And after this, the dialysis treatment has started now, sir, and I have to sit with my wife, holding her hand. So the food distribution is over by the time the dialysis is over. So most of the days is nothing. I did not ask him anything further. I knew he is hungry. What happened later on is not important. But tears surely welled up my eyes at this paradox. Here was a man for whose wife we could arrange for free dialysis of nearly 100,000 rupees or 1,00,000 rupees. But we could not arrange for a roti, a loaf of bread. That's all my story today. I wish Dr. Komal all the best. I wish all of you, I can see Nandita there, I can see Lakshmi there. May God bless you. Satam Jivam Sharad. Satam Jivam Sharad.
Thank you so much, sir. Really moved and touched by your story. We really need to introspect a lot of things when we deal with patients. And I think the overall, the holistic approach wherein we need to know there are minor problems also. You have pointed out so beautifully. It was really a great learning experience for all of us. And thank you for your wishes, sir. They mean a lot. Thank you so much. And now I take pleasure to call upon our guest of honor, Dr. Lakshmi Srikhande Madam. We know Dr. Lakshmi Srikhande Madam is the chair of ICOG. She's done such dynamic, such a great program, ICOG, like Chai Pe Charcha and so many. I think ICOG is doing wonderful job. And she's also the national corresponding editor of the Jogi Journal and national corresponding secretary of Association of Medical Women of India, former patron and president of ISOPAR Vidarbha chapter, and a lot of so many awards I think she has received, not to mention the Nagpur Ratna Award by the Union Minister, Shri Nitin Gadkari ji. So over to you, madam, to address our audience.
Thank you, Komal. Thank you so much for your kind introduction. And I am so happy to be part of this wonderful academic series of yours. And today you are discussing 3 Ws, when, what, why. And I can see Dr. Nandita, my favorite speaker. Nandita, and I am here to listen to your talk because every time there is something new to be learned from your talk. And today you are speaking on what is new in male infertility. I can see hardcore obstetrician, Professor Surekha Taide, who will be speaking on when to induce in high-risk pregnancy. And of course, the Chauhan couple, Niranjan and Komal. I like that topic, Komal, something hatke. The panel which you are moderating is the post-operative wound care, because we really don't bother so much about the wound care post-operative, and they become infected, and we just leave it to our assistants. So I'm sure it will be really something very educative, informative for all our audience to learn about this very, very neglected, I will say, taken for granted topic, that is post-operative wound care. And I heard Dr. Pankaj Desai, he was sharing his story. And I mean, yes, so much to learn from him. And wish you all the very best, Komal. Not only for this webinar, I know, but for your ongoing election campaign, and all the very best for your elections. And wish you all the very best for your future endeavors as well. I hand over back to you and wish you happy learning to all the audience. And I am also here to learn from all these learned speakers and moderators. So back to you, Komal.
Thank you so much, Lakshmi Madam, for those lovely words, and thank you for your wishes. And I totally agree with you. Dr. Nandita Madam is everybody's favorite speaker, you know. To have Dr. Nandita Palchetkar here itself is
मेरी तो है
itself is a
म्यूट हो गई कोमल तुम.
Komal ma'am, you're on mute.
No, I joined from another device. That is the reason this is the echo. So I would definitely like to say that Nandita Palchetkar Madam is everybody's favorite speaker, and we are really eagerly waiting to hear her talk. So I hand over to Dr. Anisha to introduce the chairpersons, and we begin with Madam's talk.
Thank you so much, ma'am. So we'll begin with the first talk of the session, that is what's new in male infertility. To chair the session, may I please have the CV of Dr. Aarti. Dr. Aarti is the president of Dehradun Obsgyne Society. She's a
Anisha,
director
we
of
have just rescheduled. So if whichever chairperson has joined, you introduce. I think I can see Dr. Kavita and Dr. Rachna. So we can ask them also to chair.
Okay, may I request Dr. Kavita and Dr. Rachna to please chair this session on what's new in male infertility. So can I have their slides, please? CV slides. Yeah, Dr. Kavita is a professor in head department in Obsgyne, CMC, Ludhiana, Punjab. She's also a member of Practical Obstetric Committee, FOXY, a member of Medical Education Committee 2020 to 2022, FOXY. She has many research and publications hailing in her names and won many awards as well. To be worthy of mention is Manyata Champion Award 2020 and Manyata Lead Assessor 2022. Our next chairperson is Dr. Rachna Jaju. She's the director of Jaju Hospital, Honorary Secretary, Latur Obsgyne Society 2022, member of PAC Committee amongst 20 to 2022, a past secretary of IMA WDW branch and treasurer of IG Latur 2014. She's got special interest in difficult obstetrics in USG as well. May I request the chairperson to please introduce the speaker of this session, Dr. Nandita Palchetkar, please.
Hello, good evening, everybody. So it is a real honor to introduce, actually there's no need for introduction for Dr. Nandita Palchetkar Madam. And we all know that she's such a prominent figure in FOXY and as well as in ISAR. So Dr. Nandita Palchetkar has many awards, and she has many honored posts in various organizations. And she has been the pioneer in India for many latest techniques, technologies, which is related to assisted reproductive techniques. And she has delivered so many orations, talks, authored many chapters, books,
Rita, thank you.
so many awards. So without any more introduction words, I will ask Dr. Nandita Palchetkar to please go ahead with a talk on male infertility.
Eagerly waiting to hear. Welcome, Madam.
Thank you. Good evening, everybody. Thank you, Kavita and Rachna. I think I've put you in a spot by coming in for this session. I know, but I'm really sorry. And thank you, Surekha, for adjusting your session with me. Thank you very much. And Komal, I can never refuse her. But I just, as I have, my day is like crazy packed today. So I just requested Komal, let me be the first speaker. And with Surekha, I know I can request her to allow me to go in first. So the chairpersons, had to just adjust to male infertility. I'm just sharing my talk. And Komal, I'm really proud of you, of the work that you're doing. It's amazing stuff. And I think this Global Academy of OBGY, which you are heading, is really doing fantastic work. And I think, I would like to say one thing. The elections are doing something really, really wonderful, because so much of learning is happening and so much of knowledge is out there. It's fantastic. So Komal, congratulations on this wonderful platform which you've created, and you're getting fabulous speakers. So today is my favorite topic. I think male factor is something that I really love to talk about. And did you all know that male factor did not exist before 1950? It just did not exist. There was no semen analysis before 1950. In fact, in 1950, the first paper was published, which actually had semen analysis. The counts were done, and then they identified those males who did not have children and those people who had children. And today, what you know about the count, the motility, the morphology was actually published in 1950. And this whole science of andrology started back then in 1950. It's only that much older. I mean, 75 years old. So what has happened is infertility has become a burden worldwide. In fact, 1 in 7 couples are infertile. And in fact, the WHO estimation is 15% right now. And if you look at it, the male factor contributes to nearly 50% of the couple. And the fertility rate in men younger than 30 years has also decreased worldwide by 15%. In fact, it causes in the woman also, it causes a lot of psychological and social distress. But the men, I think, because we have a patriarchal society, there's a lot of psychological distress which happens in the man. And of course, the economic burden the man generally has to bear because he's the bread earner of the family. And it has a lot of, impact on the healthcare systems also. So overall, 25% of the male infertility cases, there's no detectable cause, even after routine tests. And these cases are unexplained infertility cases. And there are a multitude of risk factors. And especially in cases of male infertility, the risk factors can be stratified as congenital, acquired, and idiopathic. And if you look at them, the abnormality can be hormonal, genetic, physical disorders, environmental factors, sexual problems, etc. So an abnormality in the hypothalamic pituitary gonadal axis, physical problems can disrupt sperm production and blockage, erectile functions, early ejaculation, inability to ejaculate, men exposed to hazardous substances in workplace and pollutants in the air, poor nutrition, smoking, alcohol, and genetic factors like chromosomal abnormalities and single gene mutations. In fact, I did a pickup of an azoospermic male where they have Klinefelter's syndrome, and we are going to do, we did a micro TC of the husband. So all these factors do cause male infertility. And if you look at the risk factor, that the semen count is declining at an accelerated pace of 2.64% per year. And in fact, male fertility has been described as a major public health problem. And, there was a beautiful article published in Fertility Sterility, which says window into the health of the patient. So we as reproductive endocrinologists not only treat the patient for fertility, but also we can advise them about future health, can advise them changes in which to prevent future health. So there are 2-3 things. I mean, because of the existing condition like pre-diabetes, etc., they are at risk of infertility. Like what? Increased risk of hypogonadism, higher sperm DNA fragmentation, non-obstructive azoospermia. But also men with oligospermia, asthenozoospermia can land up with obesity and the other metabolic syndrome problems. Men who are oligospermic are more likely to have metabolic syndrome than men who are normozoospermic. So both the things are vice versa, and we can actually advise our patients how to be healthy in the future. If you look at the tests are multiple. We have the macroscopic evaluation, which will tell us the volume, the pH, the appearance, and the viscosity. And the microscopic evaluation will tell us the concentration, the morphology, and of course, the motility, the agglutination, and the pus cells which are there. But today there are more advanced tests which are available. So let us look at it from a general gynec point of view. What are the tests that you really need to do? You need to do a semen analysis. And if you have patients of, say, recurrent pregnancy losses, if you have patients with recurrent implantation failures in IVF, and if you have girls, women with a very low AMH, then it's worth doing the sperm DNA fragmentation. As we go ahead in the lecture, I will tell you what are the advantages of that. Then people who smoke, who are exposed to high degree of pollution, it is good to know what is the reactive oxygen species, the oxidation reduction potential. Of course, I don't do it in regular practice, but you can put them on antioxidants. So these are the tests that are normally done. There are, of course, tests for where you do FISH for aneuploidies. There's nuclear maturity tests, mitochondrial function tests, but of course they are not done. But what is commonly done is the HSA and the sperm DNA fragmentation, and the culture is what we do in our practice. The sperm quality parameters, according to that, you describe the problem that the patient has: azoospermia, zero sperms, oligospermia, less than 15 million count, teratozoospermia is less than 4% normal sperms, astenozoospermia is less than 30% motility, necrozoospermia is dead sperms, oligoastenozoospermia is triple sperm defects. That means defect in the count, defect in the motility, and defect in the morphology. Decline in the seminal quality in Indian men. This was a study done on Indian men, and it has been shown that Indian men, the semen has declined with time, and quantitatively it is a higher decline in the infertile group. The significance of sperm DNA. I think this is very important to understand, that it is DNA integrity is very essential for fertilization and development of the fetus. Testicular and post-testicular. So testicular is because of testicular defective maturation or an abortive apoptosis. Post-testicular is because of oxidative stress. So we need to understand that. And so if there is a higher DNA fragmentation because of oxidative stress, and that is not coming down, you can actually take testicular sperms and get better results. So that is why the differentiation is important, whether it's testicular or post-testicular. Impaired DNA integrity is, as I said, is detrimental for the success of ART. DNA damage in the spermatozoa can affect the health and well-being of the sperm. Given that DNA delivery to the oocyte at fertilization is the main function of the spermatozoa, sperm DNA integrity is key in determining the competence of the sperm. A DNA fragmentation index of more than 30% definitely gives a lower incidence of pregnancy, whether it's by natural conception, IUI, or IVF-ICSI. So DNA fragmentation, if you look at it, what causes the DNA fragmentation? Let us look at the conditions: infections, inflammations of the genital tract, febrile illnesses, obesity. In fact, in COVID, we noticed a lot of patients having abortions, having low sperm counts. This was probably one of the reasons. Then protamine deficiency, abnormal chromatin packing, apoptosis in the epididymis, advanced age of the man. Then chemotherapy, radiation, cancer, environmental pollutants and toxins, and unexplained infertility. So potential effects I've already explained, but to reiterate once again: reduced pregnancy rate and recurrent miscarriage, suboptimal embryo quality and impaired fertilization, suboptimal ART outcome, And also genetic diseases and childhood malignancies can result from these also, if it results in a pregnancy. Oxidative stress. It's a cause of male infertility supported by elevated seminal oxidation reduction potential in 80% of the men with infertility. Male oxidative stress infertility involves altered semen characteristics, and oxidative stress affects nearly 37 million men with idiopathic male infertility. Excessive amount of ROS, if not counterbalanced by antioxidant, leads to oxidative stress and results in protein, lipid, and DNA damage. Because oxidative stress is potentially reversible, this provides an opportunity for treatment. So that is why, in general, most of the IVF specialists give antioxidants to the male counterparts. So male oxidative stress infertility. What does oxidative stress, where does it play an important part? Sperm dysfunctions affects the sperm cell membrane, impairs the sperm motility, reduces the ability of it to fertilize the oocyte, and of course, DNA damage also. So when there's increased sperm oxidative stress, lifestyle modifications, oral antioxidants are employed, and it is relatively inexpensive, easily available, and easily administered with minimal side effects. I think this is a very simple therapy which we give all people. So, the current pharmacological interventions that are available are anti-estrogens, clomiphene. So if your estrogen level are high, you can give anti-estrogens, you can give aromatase inhibitors also if the estrogen levels are high. If the patient has hypogonadotrophic oligospermia or azoospermia, then gonadotropin replacement really works wonderful. If the prolactin levels are high, bromocriptine works, and systemic corticosteroids in cases of autoimmunity. Surgical therapy, if there is varicocele plus present, it's a visible varicocele, and there is oligospermia, there's teratozoospermia, there is asthenospermia, then definitely the surgical therapy helps. Then of course, if it's an obstructive azoospermia because of some kind of adhesions, etc., those can be treated surgically, and ART definitely helps. But limitations of the current therapy are, in almost 40% of the infertile men, there is no clear etiology, and therefore there is no single therapy, and selection of a therapeutic modality is really a great challenge. So aromatase inhibitors, if we use, it decreases bone mineral density. Pharmacological therapy is only effective in a handful of known cases, as I mentioned the indications before. And hormonal therapies in general should not be used indiscriminately for the treatment of idiopathic male infertility because of its questionable efficacy and restrictive cost, definitely. So nutrition and fertility. Semen quality is generally not paid heed until it deteriorates to a level of infertility. Lifestyle factors that affect male infertility could offer a therapeutic opportunity, but it takes long. Nutrition can affect negatively or positively sperm quality, and this effect depends on both quantitative and qualitative aspects of the diet. Therefore, the role of daily nutrients needs to be highlighted to preserve male infertility. Nutritional supplements and therapy with antioxidants is the cornerstone of empirical. So you have ubiquinol or coenzyme Q10. It maintains the efficient energy system and protects the membranes. So spermatozoa energy and protects the membranes from lipid peroxidation. Beneficial effects on sperm motility and therapy of choice in asthenozoospermia. It improves sperm parameters, oxidative stress markers, and DNA fragmentation, and improved ART outcomes. Let's look at glutathione and lycopene, and definitely improves the motility, morphology, and vitality. Lycopene improves sperm counts by as much as 70%. Ginseng and amino acids stimulates spermatogenesis, improves testicular function, sperm quality, and motility. Arginine causes, improvement in sperm metabolism, and it is carnitine is most effective treatment to increase sperm motility and morphology. And there is this particular study which was published in Andrology that dietary supplementation with L-carnitine and multi-micronutrient in idiopathic male subfertility. It was a randomized clinical study, which actually says that multi-nutrient, multiple micronutrient supplementations like L-carnitine, L-arginine, glutathione, ubiquinol, zinc, folic acid, cyancobalamin, and selenium can improve sperm quality in males with idiopathic male infertility and increase the pregnancy rates. Vitamins B, C, and D, they act in different ways. C protects the spermatogenesis, prevents sperm agglutination, increasing testosterone synthesis. The B complex decreases the total homocysteine, reduces the oxidative damage. The vitamin D increases the calcium of spermatozoa, which improves the motility and acrosome reaction. And vitamin E is the testosterone biosynthesis and modulation of telomerase activity. Minerals, selenium, magnesium, zinc help in spermatogenesis. So nutritional interventions, I think this is a beautiful diagram, which actually, shows where each micronutrient and each micronutrient acts, and it beautifully is shown. So all these are necessary in their adequate amounts for the sperm to function properly. And today our diet is really deficient. If we can give adequate nutrition, you don't need these supplements. But otherwise, the supplements are necessary, especially, everybody is on a diet. They're not eating adequately. They're on the run. And in this humdrum of our lives, we definitely need it. So these nutritions are needed. Now, let us go towards the ART part. So what does one go towards the ART? Definitely my passion is ART, and I use all these nutritional micronutrient supplements. But remember, friends, how long do you give them? Have a cutoff for your patients. 3 months, 6 months, and do the AMH of the girl. Because today what we are seeing is, even if the girls are young, their AMH is 1.3, 1.8, 1.7. I know a lot of you will say, oh, my patient has conceived with 1.7. Oh, my patient has conceived with 1 AMH. But remember, these are, they are rarities rather than the norm. So you must, if you've had an experience, repeat the AMH after 3 months. If it is dropping or staying the same, please, if there is no difference in your semen count, please send them to an IVF center. I think this is our responsibility towards our patient. So what is my practice? If my sperm count is more than 5 million, then I go for IUI. If it is between 1 to 5 million, I prefer to go for IVF or ICSI. Definitely, I don't go for IUI unless the patient really insists on an IUI, or the patient is very young, or if they've never had an IVF. But even if they're young, they've never had an IUI, I would really push them for IVF if their count is less than 5 million. Less than 1 million, there's absolutely no choice. They must go for IMSI. And severe abnormal morphology, IMSI should be done in those patients. So my personal approach is the WHO guideline. If it says abnormal semen, then I would go for ART. So normal sperms less than 4%, DFI greater than 30%, post-wash less than 95% A-grade motility, I would go for IUI, IVF, or ICSI. Then improve sperm quality by semen preparation. Yes, we don't really do semen wash is not done by centrifugation or centrifugation and swim up technique. We use the dumbbell density gradient now. And for normal counts, for severe oligoasthenoteratozoospermia, for semen DNA fragmentation, for reactive oxygen, if there is reactive oxygen species, then swimmer double density gradient is much better. Now in our lab, we use microfluidics for IUI as well as IVF. It is very effective in all cases. And MAC is used in cases of high apoptotic sperms, high DNA fragmentation, except in asthenospermic samples. MAC is used in our laboratory. Now, IMSI we use for teratozoospermia, couples with previous and repeated implantation failures, high degree of sperm DNA fragmentation, and poor quality embryonic development in ICSI cycle and the aging male. Of course, IMSI is only used with when we are doing ICSI. So what is IMSI? IMSI is enlargement of the sperm to 6,400 or 7,000 when it's connected to your ICSI. So if you can see on the left-hand side, this is how ICSI is done with 400x. When we attach the IMSI to it, it is magnified 6,600 times. This sperm is selected, and then that sperm is measured, the head, the length of the head, the breadth of the head is measured, and this gives us a normal sperm. And this is PIXI, which is hyaluronic. The whole concept is the sperms with the most intact DNA go and bind to the hyaluron, and those which bound to the hyaluron, those sperms are picked up because they are the sperms with cellular maturity, viability, and they have unreacted acrosomal status. So these are the two techniques to select the best sperms with ICSI. And especially in repeated failures of ICSI and in male infertility, this can be used. Then there is a test called hypoosmotic swelling test. Now, in patients who have zero motility, but living sperms, how do you know that they are alive or they are dead? So you put this solution that is normal saline, and the membrane absorb it, and the tail curls up. So the sperms with the curl tail are the ones which are living, and those are the ones which are picked up to use for ICSI injections. So this is how you differentiate between necrozoospermia and living sperms. Okay, so this is another technique for male infertility. What else is new? We've just started the piezo ICSI. What is piezo ICSI? I don't have the video, but the ICSI, the needle which comes in, you have a sharp needle which is in ICSI. In piezo, it just vibrates like this and it creates the opening. So because of that, what happens is there's no damage to the spindle in the egg, and it does not damage any of the cytoskeletal structures in the egg. And especially in cases of, where we have very few eggs, you have patients with low amount of eggs, low AMH, patients of cancer, where we have only that much genetic material. Like the other day, I have a patient whose eggs were frozen, and she's today turned 43, and she wants to get married. She's found a partner now. So we have only that many eggs. So piezo ICSI would be fantastic for her. Then this is the poloscope. I don't know whether this is a video or no, this is a picture, I think. Okay, sorry. This is a picture. So you can see this white spot. Poloscope is another technology where you can identify the spindle. Spindle is where the chromosomes are. So when you're injecting the sperm into the oocyte, you do not hit the spindle so that you do not damage the chromosomes inside the oocyte. So in this way, you'll get better fertilization so that you don't damage the egg. Now, especially useful in cancer patients where you have less number of eggs. So all these technologies are to improve the pregnancy rates with patients who have very less genetic material. Then percutaneous retrieval, I think obstructive azoospermia, we have 100% retrieval rate of sperms. It is an it's an excellent technology where you know that the CBAVD, where there's congenital bilateral absence of the vas deferens. Of course, you have to check out for the mutation of cystic fibrosis, and then go ahead with this, and you get very good sperms by just putting in a needle into the epididymis and aspirating out the sperms, and the success rates are equivalent to an ejaculated sample. But this is, which is very beautiful, the micro TC, where you can see that the tubules which are turgid are identified under the microscope, and these tubules are then biopsied by our andrologist and sent to us. We work with Rupin Shah, and in fact my fellows from MUHS fellowship student is doing the thesis, and we've just got the data of 103 patients of micro TISA, which we've done with Rupin. We've achieved, we've found sperms in nearly 75 to 80% is what they're telling me. We've got sperms from these rigid, and believe me, the FSH levels are 23, 25, 30, those kind of FSH levels. But this technique of micro TC is fantastic. And let me give you the good news. ESAR, as a ESAR president, we went to the government and we sat down for 3 to 4 hours, and we told them that you don't need only a MCH urologist to do this procedure. And with the efforts of everybody, I think the central team also had a meeting and they pushed it. And we now today, all surgeons, all fellowship candidates and all MCH urologists can perform this. So that was a major victory for us, and it is giving fabulous results. Even in Sertoli cell only syndrome, you can get sperms, and our pregnancy rates, I think, are around 25 to 30%. So we are going to publish this, and it's a fantastic technology. And of course, the last thing is you can create sperms from stem cells, and this mice have been created in the lab from stem cells, and that would be, it's not yet done in the human beings, but I'm sure it's not far away, and we will have a creation of sperms from the human beings. Thank you very much. And Komal, thank you very much for giving me this opportunity. I'm so happy to be here. And I think Lakshmi, thank you for being here. Lakshmi has always, done a wonderful job as a chairperson, and it's always a pleasure. She always comes with innovative ideas totally. And Komal, all the best for your elections. I'm sure you'll do well. And I know how hard you work, and I hope all your efforts pay off. All the best.
Thank you. Thank you so much, madam, for your lovely wishes. And it was a wonderful talk. Really an eye-opener that so much can be done. And all the evidence is what you said. So over to you, Chairperson. I can see Dr. Aarti also has joined finally. So if you have heard the talk, we will take your comments also, and Dr. Rachna and Dr. Kavita.
Lakshmi, thank you for being there. Lakshmi, thank you for being there.
Nandita, I was waiting for learning and listening to your talk. It was really too good. The way you explain and the things you make out from your talk, wonderful.
Thank you. Yeah, Aarti, sorry, I gave a talk before.
Yeah. Madam, I just want to say that I was there throughout the talk, and I have also learned, and your passion, your passion while you explain, and really, I think from A to Z, everything in that half an hour, that is also a great feat. And I that's why you're such a popular and favorite of us all. So thank you so much, and really learned a lot. A really wonderful job.
Thank you.
Congratulations, Dr. Nandita. A crisp and complete talk as always. Your collection of material is so good, and you have beautifully covered the WHO guidelines, effect of lifestyle modification, oral antioxidants, role of pharmacological interventions, surgical treatment, and ART, and the guidelines as per WHO. It's a pleasure hearing you always. And I must congratulate Komal for organizing this beautiful webinar with very good topics, and lots of good wishes, Komal, for your victory with huge numbers. Yeah.
Thank you. Thank you so much, Aarti. Yeah. Dr. Rachna?
Kavita
Dr.
and
Kavita,
Rachna.
yes.
Just wanted to say one sentence, ma'am. I met you sometime in 2020, and I was so awed by you because I was meeting the past president of Foxy, and ma'am didn't know me. So I introduced myself as a Wonder Foxian.
Oh.
Because we had recently got that award as a Wonder Foxian in 2019. It's such a pleasure listening to you, ma'am, always. So much to learn from you. Thank you so much, ma'am.
Kavita, I'm so proud of you. I'm so glad you took the effort for it because so many people do so much work. And I'm
Thank you.
glad.
Thank you.
Rachna.
Yeah, ma'am, it's a matter of great honor and pride to chair a session where you are the speaker, whatever topic you are taking. It's just honor for us, and it was truly an enthralling lecture with very beautiful insights on male factor infertility. Thank you so much, ma'am, and thank you, Komal ma'am, for this wonderful opportunity and many best wishes.
Thank you. Thank you so much.
Thanks, Rachna. Thanks, Komal.
Thank
Komal,
you,
I have to run, Surekha. I have a very packed schedule today. Okay.
Okay, thank you.
Thank you. Bye-bye.
Thank you so much. Thank you.
Yeah. Yeah, we can start.
Also take your leave. Bye.
Yes, thank you. Thank you, Lakshmi Madam, for being here. Thank you so much.
Bye.
So, Anisha, we will start the next talk, but we can ask the chairpersons to be there. And Rachna, you can introduce our speaker, Dr. Surekha Taide. And we can ask both the chairpersons, Aarti and Nilesh, also to be there.
Can I?
May I please have the CV of Dr. Nilesh?
Yeah, can we have the CV of Dr. Surekha? Yeah, Rachna, you can start.
Yeah. It's with great honor. I would like to introduce Dr. Surekha Taide. She is a member of Education Committee, Indian Menopause Society, chairperson of Global Women's Health Task Force, founding member and vice chair, Women's Health Together for the Future South Africa. She's a national mentor, then master trainer for emergency obstetric care, critical obstetric care. She's expert committee member in a national guideline for obstetrics, co-leader in maternal near miss project, co-leader for maternal death audit project. She has numerous publications. We can say it's humongous. She has 108 national and international publications to her accolade. She has 16 projects. She has done 16 projects and written 8 chapters in books. So she's now a member of IAEC, Endocrinology Committee, Family Welfare Committee, Foxy. She's recipient of the prestigious Savitribai Phule Award and Dr. Anand Jivne Award. We welcome you, ma'am, and over to you.
Thank you so very much, Rachna. And at the outset, I would like to thank Komal for her wonderful, wonderful work she is doing through this Academy of Global and her trending ask. And she's my very good friend and a great academician and very hardworking, I must say, the type of work she's been doing, and we are all privy to her efforts. So first of all, my best wishes to you, Komal, and of course, the work you are doing will definitely bear fruit, and we will all see you as a winner in the coming elections. Thank you so very much, my chairpersons, for being there with me. Is my slide visible?
Yes, it's still, yes. Make it full screen. Yes.
Yes. So thank you very much for being there for this talk on induction of labor in high risk pregnancy. And specifically, we will answer the question, when, when, what, why is today's theme. So we are going to answer this question on induction of labor in high risk pregnancies. Now, what is induction? Induction of labor is undertaken in the opinion of the physician when the risk of delivery to the mother, to the fetus, or both are less than the risk of continuing the pregnancy. So when you think that the risk of continuing the pregnancy is more, in other words, we're going to induce this labor. What is this induction? It is the process of artificial stimulation of the uterus. These techniques for stimulation are, prior to the onset of labor, definitely. And between 1990 to 2019, the overall frequency of labor induction has actually tripled from 9.5% in 1990 to 29.4%. So now we are having huge number of inductions in our delivery wards, and we need to discuss when and why we should be inducing these patients. So all pregnancies carries risk. What are high risks? These high risk women or high risk pregnancy are when the mother and child are having a greater risk of complication than when you compare to the normal cases. And there can be a threat to the life of the mother or the fetus. So in these cases, we need to be extra careful, extra alert before, during, and after the childbirth, so that we reduce the possibility of complications in these pregnancies. Now, these are all the indications of induction of labor. We all know the prolonged pregnancy, FGR, preeclampsia, that means all the hypertensive disorders, PROM, chorioamnionitis, placental abruptions, GDM, twin pregnancies going beyond 38 weeks, isoimmunization, fetal malformations which are incompatible with life, and certain social regions. All these can be considered as high-risk pregnancy in one way or the other. Now, what my talk is going to go through these case discussions, which I'm going to elaborate. So first case, now there is an optimized primea gravida at 40 weeks of gestation with good pelvis, average size baby, non-compromised baby. Cervix is, however, long, uneffaced, and head is at higher at -2 station. Question is, how will we proceed? In which cases you would like to start ripening or induction? That is our original question. So she is at 40 weeks. She is just crossing her dates. Are you going to induce this patient? Now, before you do talk of induction, before you need to assess the patient very well to look at what are all the maternal factors. Is there any comorbidity? What's the history? What investigations she has undergone? Are there any comorbidity? So basically, before taking decision for any induction, you have to review the whole case of the patient. And if there is no indication for induction, we may go on till 41 weeks of gestation. That is 1 week we may prolong, depending on, what is the maternal and fetal surveillance. Let's find out how is the patient, how is the fetal well-being. You can do a cardiotocograph. You can reevaluate the patient in 2 to 3 days time, and appropriately we can take a timely decision. If there is any indication, we may intervene. If there is no indication, then we can go up to 41 weeks of gestation. There are certain contraindications for induction, like if there is a major degree of placenta previa, vasa previa, if there was a classical C-section, any prior uterine surgery, cephalopelvic disproportion, active herpes, invasive carcinomas, and hypersensitivity to cervical ripening agents. So a history is very, very important. And of course, conditions where IOL is not a true contraindication, but a special precaution is needed is if there is a multiple pregnancy, polyhydramnios, grand multipara, maternal heart disease, CV hypertension, breech presentations, we usually don't do any inductions, and one or more previous C-sections. If it's a previous C-section, again, we are very careful. Abnormal fetal heart rate, not requiring emergency C-section. So again, we have to be very careful why these abnormal fetal heart tracing is there. So these are not true contraindications, but we need to be very careful about this patient. Our original question was, when induction of labor may be appropriate. So this is the WHO document, and WHO document says that induction of labor is recommended for women who are known with certainty to have reached 41 weeks of gestation. So beyond that, we are not going to continue the pregnancy. Induction of labor is not recommended in women with an uncomplicated pregnancy at a gestational age less than 41 weeks. However, in many times, we just find that 40 weeks, if it is crossed, then we are very careful. If GDM is the only abnormality induction of labor, before 41 weeks. Now, again, this is little controversial. The strength of evidence is weak. I will be discussing more on GDM and when to induce in my later slides. Induction of labor at term is not recommended for suspected fetal macrosomia. Induction is not recommended for women with PROM at term. So if there is a PROM at term, there is a strong recommendation that you may induce this patient. For induction of labor in women with an uncomplicated twin at or near term, no recommendation was made. So individualization of cases when there is a twin who is going nearer term. So that is the WHO document. We will discuss further individually case-wise. So here is a case now, Primi Gravida, who is 41 plus 2 weeks. You have evaluated her. Now you have decided to induce her. Now question is how to assess, how to prepare, what should be the important points as far as consent of this patient is concerned. So for evaluation, we need to confirm the indication. We need to confirm the gestational age. Sometimes the patient has wrong dates. Her gestational age is not confirmed. We need to evaluate and assess her to rule out any contraindications. What is the fetal position? What is the fetal presentation? What is the estimated fetal weight? Doppler, the CTG, the FHR pattern, that all will tell us what kind of risk there is for this patient, where is the pelvis adequate, what is the Bishop scoring, all this we need to. So this Bishop scoring, we are all very well aware of. This will tell us whether, a ripening would be needed for this patient and what method would be suitable for the patient. Again, consent is so very important. Before going into induction, you need to sit with the couple and talk to them, and relatives also. Many a times, we need to give them the pros and cons of why we are inducing, what method, give a practical view, how much time it is going to take. Sometimes it takes even 48 hours for the ripening and then induction. So you need to actually explain everything to the patient and relatives so that, they are on the same thought process as yourself, and explain to them importance of patience and waiting for things to happen. So because it's not going to happen immediately in 4 to 5 hours, it's going to need a long time. So possibility of an emergency section, if there is some FHR abnormality or pathological trace, we need to all talk to them about emergency C-section, which may be needed anytime. And of course, written consent has to be in the local language. So everything which you have explained has to be on the consent form, and then you may go ahead with the method of induction after discussion with the patient and relative. So that's very, very important. So this is one article which tells us that this is a qualitative analysis of almost 2,400 women, and many of the women are saying that they were not very well informed about their elective inductions. 21% of the respondents actually said that they really were not knowing about the risks associated with the induction, and they were so it's very important there that you give a correct information, you talk to them about the indication. So this, is very important that you really talk and tell them why you are doing it and what is the expected outcome. So when to induce? So if it's a growth restricted singleton, otherwise uncomplicated, you can go up to 38 weeks. Growth restricted singleton with oligohydramnios, then again there is a window period, you go up to 34 weeks, and then 34 to 37 weeks. Each day you are the pregnancy is being continued. You have to assess the mother, the baby, and accordingly the Doppler studies, the CTG will tell us when to induce. If only oligohydramnios, then again 36 to 37 weeks. Twins, then around 38 weeks. Twins monodi are 34 to 37 weeks. Gestational diabetes well controlled on diet or medication. Early birth not indicated. Gestational diabetes which is uncontrolled, you have to individualize the management. Pre-gestational diabetes which is well controlled, no need to induce early. Pre-gestational diabetes uncontrolled, again individualization. If there is vascular complication, again, around 37 weeks of gestation. Placenta previa, we usually don't, don't induce placenta previa. If there is percreta, accreta, you have to terminate around 34 weeks of gestation. Again, a cesarean section is needed. History of classical C-section, we don't induce. We may go for a C-section around 36 weeks. History of myomectomy, we don't induce. We may go around 37 weeks of gestation. Termination by cesarean section is advised in this kind of case. So now, another question is ripening important before induction? What are the ripening agents to be used? Which one to choose over the other? And how many times will you repeat these ripening agent, and when you will give up and go for the C-section? So these are the various, these are the importance, and this is how the ripening agent acts by collagen breakdown, softening the cervix, inflammatory infiltration by the cytokines. So basically there is a degradation of the collagen, and that is how the softening or the ripening occurs. There are various ripening agents, as you can see on the screen, starting from herbal supplements to breast stimulation, up to you can go to mechanical dilators, balloons, membrane stripping, prostaglandins. So there are so many things, and again, there are pros and cons for the route, dosage. So many things are there, and we do have the prostaglandin preparations like dinoprostol and misoprostol. We have all been using, and the question is which dose, which route. Most of the time, if you're talking of misoprostol, vaginal administration at a doses, we start with a small dosage and we go in incrementally. We may take 4 to 6 hours, and then of course we may think of if there is a good contraction, we may supplement with oxytocin, or we may just go ahead with an incremental doses until optimal contractions are achieved. Oral admissions, the concentration peaks sooner and declines more rapidly than vaginal administration. You can even use a sublingual administration. We all are aware of dinoprostol. We have been using the gel. Those can be repeated every 6 to 12 hourly. Maximum cumulative dose of dinoprostol not to exceed 1.5 milligram. Interval can be 6 to 12 hours, depending on, what is the ripening has occurred, what kind of uterine actions are there, contractions are there. Depending on that, we can use. Now, there is something called as Cervidil. It is a vaginal insert. It contains 10 milligram of dinoprostol with a timed release formulation. Again, this is a very good agent for inductions, and oxytocin may be initiated anytime beyond 30 minutes after removal of the insert. So this is the advantage. Depending on the contraction, depending on the FHR pattern, we may think of supplementing with oxytocin. So again, Cerviprime is another very good agent which is being used, and it's a pre-filled syringe, and all of us are aware of Cerviprim gel, and we do have a lot of experience with Cerviprim gels. So many different methods have been used, but prostaglandins remain a preferred method for ripening as well as induction. Overall, misoprostol may be a best prostaglandin for labor induction, as titrated low dose is safe when you're talking of misoprostol. Now about oxytocin. Question again is when to use oxytocin. What should be our safety points? What should be our goal? So as far as oxytocin is concerned, 6 to 12 hours after the final dose of misoprostol or dinoprostol, you have to give that 6 hours interval, and then you may start up with oxytocin. We use oxytocin in titrating doses with slow increments, and with we are quite watchful and alert. So again, for oxytocin, there is no fixed dosage. Usually, we will incrementally increase the dosage till we achieve the optimal contraction for that patient. Another question is how to monitor. Is the electronic fetal monitoring necessary for all your patient, and what alerts should you look for on the CTG, and when you can call as failed induction? Now, as far as monitoring is concerned, fetal well-being has to be established prior to the induction of labor. That's very important. And after vaginal prostaglandin, again, you check the fetal well-being when contractions are detected or reported. And of course, that's very important. If the CTG is suspicious or abnormal, then you may stop the infusion of oxytocin if you are giving oxytocin. And again, you have to be very much alert when you're talking of. So these are the CTG, pathological CTGs. As you can see, some decelerations are being seen on this. The third one actually shows oxytocin. This was an oxytocin drip, which led to this prolonged deceleration. So you have to stop the oxytocin or the induction when you're, when such kind of abnormality is seen. Let us go to the case 3. Again, 37-weeker came with frank leaking. Should you induce this patient? Now, as far as PROM is concerned, when membranes rupture after 37 weeks, the women should be offered induction of labor or expectant management. If you are doing expectant management, that expected management should not proceed or not exceed more than 96 hours. You have to be alert for chorioamnionitis. Vaginal prostaglandins cannot be used, oral misoprostol or oxytocin, depending on the Bishop's score for this patient. Now for the case 4, this is a patient of previous LSS and she has a intrauterine demise. Would you induce this patient? And definitely she is upset. How would you go about the counseling and what would be your approach? Important is, of course, giving the emotional support, counseling the patient and relatives, and depending on the cervix, you will have to, decide what kind of agent you're going to use. Definitely, we'll have to investigate for coagulopathy. If the cervix is favorable, use oxytocin. Otherwise, you'll have to use mechanical dilatation. Many times, we find that Foley's catheter is a good mechanical dilator, and in previous cesarean sections, that is considered as a first step, and then we may think of using oxytocin. Now, another patient, suppose this is your patient with ICP and hepatic enzymes are borderline raised. Will you admit? Will you induce? When to induce is the question. Here again, assessing the situation, coagulation profile, optimizing the coagulation status, and usually in these cases of intrahepatic cholestasis, we will induce at around 38 weeks of gestation with a standard induction protocol. Now, suppose this is the case, uncomplicated heart disease, 40 weeks of gestation, NYHA classification 1 to 2. How to proceed? Whether you're going to induce this patient, usually these patients will require a thorough evaluation. You have to have the cardiologist on board. What is the functional status of the patient? Do the ECG, do the echo, optimize the patient. And if you take the decision of induction, mechanical method is the preferred induction method. Avoid prostaglandins. If you're using oxytocin, use small titrated doses. Avoid IV fluids. And of course, the propped up position, oxygenation, that's important. But if you really take the decision to induce, it is the mechanical method which is used. As far as twins are concerned, if it is a DCDA twins, both babies are by vertex, you may induce at 38 weeks of gestation. And of course, even a simple stripping of the membranes in twins is a good process by which the induction actually occurs. So estimate the fetal weight, what is the presentation position, calculate the risk, what is the Bishop's scoring. If favorable, you just sweep. You may start a very small dose of oxytocin. Use of prostaglandins is again a dilemma. Continuous electronic fetal monitor may be needed, and team has to be on high alert for PPH in case of twins. If the patient is of GDM, gestational diabetes, she is optimized, her sugar is optimized, 38 weeker, would you induce? When to induce? What is the approach? Now, in cases of well-controlled diabetes, there is very little evidence to support either induction or expectant management. Induction at 38 weeks shows lower rate of macrosemia. So around 38 weeks, you may think of inducing this patient. You have to be alert for shoulder dystocia. Now, if there is poor glycemic control, you have to look at other comorbidities, and of course, if it is before 36 weeks, you have to give corticosteroids to these patients. So finally, we come to the take-home messages. After all these cases, what we learn is that induction of labor should be performed only when there is a clear medical indication for it and the expected benefits outweigh its potential harms. In applying recommendations, consideration must be given to the actual conditions, wishes, preferences of the woman, with emphasis being placed on cervical status, specific method of induction of labor, associated conditions such as parity, rupture of membrane, everything has to be taken into consideration, explained to the patient and relatives, and their preferences also have to be taken into consideration. IUL should be performed with caution since the procedure carries the risk of uterine hyperstimulation and rupture and fetal distress. Wherever no induction of labor is carried out, facilities should be available for assessing the maternal and fetal well-being. Women receiving oxytocin, misoprostol, or other PGs, prostaglandins should never be left unattended. That's very, very important. You know, you should never give the misoprostol and allow the patient to go home. There should be someone to monitor her. Failed induction of labor does not necessarily indicate C-section. Sometimes, you know, my own professor used to say, you just wait for a few hours, 12 hours or 24 hours, and the patient will go in labor. Wherever possible, induction of labor should be carried out in facilities where C-section can be performed. So if there is any indication, you should be able to do an emergent C-section. That is the very, very important take-home message. IUL should be done for an appropriate indication with an appropriate method. Strict monitoring during the procedure is important, and this can help in early detection of complications so that timely interventions can be done and you will have a safe mother and a safe baby. Thank you so very much for your patient listening. Over to the chairpersons, please.
Thank you, Dr. Surekha. I think that was such a wonderful talk. Very important points that you have covered, and especially when we are talking about reducing the cesarean section rates in our institutions. So it is very important that we induce only when there's an indication and use the correct method also. So that will also help in bringing down our cesarean section rates.
Yes,
Thank you,
definitely.
Dr. Surekha. Wonderfully
Definitely.
delivered that.
Thank you. Thank you, Kavita. Yeah, Anisha.
Any other chairpersons would like to ask anything or comment something? Then, or else we'll proceed on to the next talk.
Shall I just ask Dr. Surekha one question?
Yeah,
because I don't use oral misoprostol for induction. So what is your...
we do use either oral or sublingual misoprostol in cases of pre-PROM. You know, when there is a PROM, membrane is already ruptured. So we're not going to use vaginal misoprostol. At that time, we use oral misoprostol. There is a quick rise, but the decline of
also
the
abrupt.
contraction is also
Yeah.
there. So basically, we use sublingual more often than oral.
Thank you so much.
Thank you so much, chairpersons and Surekha ma'am. That was a very interesting talk. We would move on to our next session, which is optimizing post-surgical wound healing. May I request the moderators, Dr. Komal Chavan and Niranjan Chavan sir, to please proceed with this. And I would request the moderators to introduce the panelists.
Yeah, thank you, Dr. Anisha. It was wonderful listening to Dr. Surekha Taide, Nandita Palshetkar. Komal has just joined another webinar of AMOGS. So she will be joining. In the meantime, I would like to continue and start the panel discussion. Well, thank you so much, Dr. Anisha, for being there today. We have expert panelists and we are going to discuss something which is very important in our day-to-day practice. And I welcome Dr. Kasturi Dominath. She has already been introduced beforehand. Welcome, madam. Next,
Yes, thank you, sir. Thank you.
Dr. Jayamala Kumaravel. It's nice to meet you. You are a consultant laparoscopic surgeon from Salem and the president of Obstetric Gynec Society of Salem. Welcome,
Thank you.
Dr. Jayamala.
Thank you, Dr. Saman. Thank you.
Dr. Astha Lalwani, I hope she is joined today. Thank you, madam.
Yes, sir.
You
Thank
are a professor from Chennai, and here it's written Moradabad. You have taken a lot of diplomas, which includes of ultrasound, ART technique, and there are basic course in biomedical research. There are many publications which you have done. Welcome.
Thank you, sir.
Dr. Rajashri Paladi, she is the honorary secretary of KASOKA. I hope she is there today. And she's been the director of Aditya Multi-Speciality Hospital from Gulbarga. Welcome, Dr. Rajashri. There is Dr. Banashri Bhadra. She is also a professor from West Bengal. She has done her medicine, College of Medicine and JNM Medical College. She is the vice president of Kalyani Society in 2018, president of the same society in 2019. Welcome, Dr. Banashri Bhadra.
Thank you, sir.
Next, Dr. Anand
Sorry to
Bagde.
interrupt, sir. Anand sir won't be able to join. He has got an emergency.
No, it's okay. We will pass on his questions to other fellow panelists. Next. Dr. Vinita Awasthi, she is also from Kanpur. Next. So I think we will go ahead with this panelist. The others will join soon. I would like to share my screen now. So why wound gape is there? And we need to optimize wound post surgery wound healing. So welcome to the episode W, when, what, and why. And today is the 26th July 2023. We are doing the episode W. So I welcome all the panelists and thank you for being there and spending your valuable time. So my first case is about commonly a wound infection which we come across. This lady was 25-year-old, primigravida. She had referred from a primary center with non-reactive NST to our hospital. General conditions looks fine. Per abdomen, full-term uterus, cephalic, regular, fixed, having 2 contractions in the duration of 10 minutes, each lasting for 40 seconds, 3 centimeter dilated, 30% effaced, membranes were plus. And ARM was done, so it was a thick meconium stain. So she was taken up for emergency LACS in view of meconium stained amniotic fluid with fetal distress. She was then, post-operative was uneventful. She was discharged. And we have a family planning OPD where she followed up on day 13 for suture removal. So this was, the sutures were opened and the wound was not healthy. Per abdomen, uterus was involuting, and per vaginal, there was no foul smell and discharge and no active bleeding. So this is a common scenario which we come across in a tertiary center like us. So Dr. Kasturi, what would you do next now in such circumstances? Would you like to admit her, or would you like to treat her on OPD basis? And would you like
the wound is, yes. So the wound is quite big and then it's totally gaped from
It is a full length gape, yes.
Yeah, full length gape. So we need to admit her.
Yeah,
we need to admit her and evaluate her actually. They admit and then we have to see what is the cause for her infection. Why? Because was she anemic? So
yes.
complete full blood count. So we have to investigate her in detail. Was she, whether her blood sugars are high?
Yes.
And sometimes these patients, not just that infection, the infection might have spread inside and she may be in septic shock.
That
so
is the
we
worst
need to do
scenario.
Yeah, worst scenario, sometimes we do get cases like that. So
Yes, we have got, madam.
do all
Yes.
the inner function tests.
So all
So
the
in detail, we
investigations were
investigate them
done.
in detail.
Yeah, investigations were done. Everything looks fine. So that was quite heartening. And I would proceed to Dr. Jayamala.
Yeah.
Now, what drugs we start? We have already given her, certain drugs at the time of surgery, prophylactically. However, some
Yes.
patients have, for whatever reasons, though the investigations are normal and, we have sent a wound swab, but by the time it will take at least 3 days for them to come. So what
Yes.
do we do next, madam?
No, you have to put her on a broad spectrum antibiotic covering aerobic and anaerobic. So,
Yeah.
I would start her on IV antibiotic if she's admitted.
Yes.
With that much of a wound gaping, definitely there's an infection which needs a broad spectrum IV antibiotic.
Yes. And
Covering
madam,
both
now further as the days have passed, now you can see the wound has totally gaped. It has gone up till the rectus sheath. If you zoom and see, and subcute, and they have done debridement also, and now post debridement wound is healthy. So that was quite heartening. However, some unfortunate patients, as Madam Dr. Donimat said, that the pus can enter inside and then it can go in septicemic shock. But luckily, this patient was not so bad. And as you said, we need to have a good antibiotic coverage, which takes place for gram-negative, gram-positive, anaerobic, metronidazole, and piperacillin. And then she was taken up for a secondary suturing. Patient was, I recollect that we used to tell our patients also, and our seniors used to tell, pet pe sona. So we used to turn them on the prone position. Do we still go ahead and do this for certain cases now also in the ward? Just a curiosity from my side.
We don't do prone position.
Sometimes if some collection or something serosanguinous discharge is there, sir. Sometimes on the dressing when we do post-operative day 2 or 3. So sometimes we come across that patients are advised, lying on the prone position. But I'm not very sure whether the literature supports that.
Yes. So
We are
there is
not
no
doing it.
mention here. So there is no mention of prone position, but as you said, if there is a very copious type of a discharge,
exactly,
and it is too, we do the dressing in the morning, and we find that within the next 2 hours, it just again fills up.
Gets wet.
So gets wet, and then we need to rest. So we used to usually keep a lot of, plastic drape of that, and then gauze piece, and again a Dynac drape and something like that. So you need to do all these things, and secondary suturing is done, and the patient was discharged on linezolid and tab metro further. Well, the alternate suture removal was done on day 14 and day 15 of secondary suturing. So we went ahead on slowly, and luckily this patient was fine and lochia was healthy. Uterus was well contracted when she followed up. So this is a quite common situation of, in a tertiary center. And you can imagine if such situation occurs in a private setup, how much, we have to be very careful in getting things done. So now I would like to ask Dr. Astha Lalwani, what to be done in a morbidly obese patients to decrease the wound gape? There are so many patients who are obese. Now we do hysterectomies, we do cesarean sections, and then
exactly. Sir, morbidity itself is a risk factor, definitely, for surgical site infection. So we should actually first start with the risk stratification right from the beginning, like it's pre-operative, intra and post-operative care. So first of all, whenever we are preparing the patient, all those things are well listed in the literature. We should ask them to take bath and all those things. It goes along for every patient, and especially if the patient has a big panniculus or the obesity. So we have to make sure that we clean that area at least for 2 minutes to make it, the infection, to decrease the infection risk. Then when we are actually taking the patient for surgery before closure, again, the hemostasis should be ensured, because that fat is a place, if we leave any vessel, if we leave any small bleeder also, that hematoma will actually be there And this
Yeah,
prevent the
yeah. I want to ask
approximation.
you.
Yes, sir.
I want to ask you, my residents, when they do a cesarean section, and I want to ask generally if you're in a tertiary center, they waste a lot of time, cauterizing all those points before delivering the baby. So you just
That's
mentioned about that there is to be adequate hemostasis, but
after
like,
delivery of the
yeah,
baby.
after delivery of the baby, but initially only they start, cauterizing all this.
That's not needed. Yeah.
So that is not right actually,
Exactly.
because you're closing the mode of blood to be there around so that the healing will occur. So never do such things. No, what do you say? Right?
Yes, so that's true. It
And
should
the
not
end
be
of
overzealous cautery and all should not be there, definitely.
Yes.
And if the wound, usually if the obesity in obese patients, they say that if the size of the fat, the depth is more than 4 centimeter, we
Yes.
should go for subcutaneous drain placement. So that is actually supported by the literature as well.
Yes.
And the closure of the fat is also sometimes written, but which I personally don't find it quite fruitful in my cases. It's always better to put a drain rather than closing the fat with catgut. Many of my residents, even I come across some patients, so I just ask them, what did you do for this patient? So in the emergency, when in the night they are taking up the patient, they'll say, madam, humne fat ko stitch kar diya. So that's not my forte. I always prefer to put subcutaneous drain if at all needed. And that also in the obese patient where the fat layer is almost more than 4 centimeter. So, and then the closure, preferably the difference by putting mattress or subcuticular suture, there is not much of difference, sir, according to me, that how will be the post-op wound recovery. So I still go for subcuticular closure, but by putting a proper drain. So that is the thing which I want to.
One thing I would like to stress here that you need to charge the subcutaneous drain once that drain is connected to the suction.
Negative pressure, yes, sir.
Pressure. So what happens? The first day you will have some fluid coming, which is serosanguinous. Second and third day. By the end of the second and third day, that recharge dabba has got lost somewhere.
Correct. Yes, sir.
And I am asking them, where is it? Where is it? So bathroom mein gir gaya, idhar gir gaya. So it is very important, it is so, it needs to be put in a proper place, where she is putting it. And it needs to be recharged every
day on the dressing, once in a day.
Yeah, once a day at least.
Once a day at least.
Yes, otherwise the purpose of that drain doesn't, thirdly, over a period of time that it is just hardly 2 millimeters in the diameter, you find that it becomes blocked also.
With the fat.
Yes, and it's not that we can flush it with some syringe or something and then, the fluid comes. All these are very small things, they need to be meticulous dressing, asepsis, wearing gloves, scrubbing, all these things are very, very important. And probably, there are many, the turnover of patients are much more, but they have to have a proper understanding of asepsis and doing this. So I think that's very important that you have managed this very nicely. Now we move.
So I just want to differ here.
In the obese.
Yes. Hello.
So one more thing I want to stress in these obese patients, sometimes what happens, we try to just give them overzealous dressings. Because हमें लगता है कि even patients को लगता है they try to give all those what do you say binders and all.
Like Dynacrepe, and you totally
exactly
enclosed it. There is no air.
So
there is no perforation.
Exactly. So
ventilation.
Exactly.
Ventilation has to be there.
Correct. So in these patients, rather we should be more particular in giving them a well ventilated wound. So this also should be actually a good point to be stressed upon when we are dealing with such kind of, obese patients.
Yes, and especially when it is moisture, if you are staying in a place where there is a lot of moisture, rainy season, no sunlight, or seasonal variation where you get cough, cold, and viral infections in the city of Mumbai, when the weather changes, everyone here starts coughing. Or when there's from summer to rain. I mean, these are all practical points. These are not written in any books. So, you need to understand that all these things, dampness, wetness, moisture, all these things are also going to affect your
Wound healing.
Apart from the best surgical skills you have or the suturing technique, and it can be happening with anyone. So now we move on to the next one. This is obviously, you can see that there is a big tear in the perineum. So I'll briefly go. This was a lady, 20-year-old, post-dated pregnancy, and she was gravida to living one at 40 weeks. She was planned induction of labor. She was admitted to the maternal ward. Rest her parameters were fine. Uterus was full-term cephalic, foci palpable, and the os admitted tip of finger. Cervix was soft, uneffaced posteriorly. She was induced as usual. All the consent and everything was taken, and she was induced with misoprostol, which was inserted on PV examination. On Bishop's score, the cervix later on, further improved. However, with all the best efforts, she landed up with a perineal tear while delivery. Now, this is how it looks, and once you put a finger, you can see that it is totally, very luckily the rectum is saved and the whole perineum is bursted out. Now, this situation I had seen in my first post when I was there, and of course, it was, we will come to different types of perineal tear. I want to ask this question, Dr. Dominath, you can take this. How would you, what would you say that it is a perineal tear? I mean, how could you differentiate with a 3rd degree or a 4th degree, a different types of perineal tear which we come across? Madam?
Hello.
Yes, madam, we can hear.
Yeah. Actually, a simple perineal tear is like just the mucosa and the skin is this thing. Then the 2nd degree is like the muscles are also involved. And 3rd degree is the most worrying thing, where external anal sphincter is involved.
Yes.
Again, that is again divided into like how much it is involved, like A, B, C. So if it is like less than 50%, more than 50%, or external as sphincter, then we grade them as A, 3rd A, B, C. And the worst thing is 4th degree, where even the anal mucosa, anal epithelium is injured. So these are the different varieties. So even the 1st degree usually heals by itself, but the later ones needs all the.
Absolutely. So we will come to the classification, madam, but I agree with you. The important thing is that you need to, at the moment when such a situation occurs, you need to identify which degree you are managing. 1st degree, 2nd degree, or 3rd degree. And of course, if it is an anal sphincter involved, madam, would you like to treat it immediately there and then, or you would like to now just wait and watch and then probably take her later on? What is your...
Immediately. We do it immediately.
Okay. Madam, Dr. Lalwani and Dr. Banashri, is she there? Yes?
Yes, sir. Yes, sir. Definitely immediately.
Immediately. Okay.
During delivery, you have to, until it's chronic perineal tear. So we don't want it to become a chronic perineal tear.
Yes, I agree with it. Sir.
The results are best postpartum. Immediately the results, the healing, it's all best. The tissues are good.
Now what happens? No, madam, sometimes, unfortunately, they are delivered outside.
That is correct.
And they are transferred here.
Yeah.
And they are transferred here probably after 10 hours or after 24 hours. Now, in such situation, what do? They do not have a skilled senior gynecologist on call. This has occurred outside, probably some 50 kilometers away from your hospital. In such circumstances, the patient, if it lands up after 24 hours, what do we do then?
Then too, we have to delay, sir. If it's just before, soon after delivery, 12 to 24 hours, we should take her up. Beyond 12 to 24 hours, it's always better to defer the case and take the patient for repair, at least after 3 months.
Yes, absolutely. So I think this is very important. Dr. Jayamala, are you there?
Yes, Doctor.
What are the causes of perineal tear? If Banashri is there, she can also answer. I can't actually.
Big baby.
Yes.
A big baby. Yeah. Sometimes, false instrumental deliveries.
Yes.
shoulder dystocia. Even after the head has come out, and after that, like if you don't give good support, you can end up in a third-degree perineal tear. Or if the baby comes out like face to pubis, those kind of when the diameter of the head is more. Even in precipitate labor, like if it comes out quickly before the assistant gives a support, proper perineal support, even in precipitate delivery, you can have, even if it is a small baby, you can have a perineal tear.
Yes.
So
I think instrumental delivery also is a very important way, where you're applying a forceps or a vacuum. The best of the best perineal tear can occur in the best of the best perineal supports. So
even with our episiotomy, yes.
Yes,
and
even with that.
I have seen a baby falling in the bucket down also with the best of the best perineal tear. When I was a houseman registrar in those days, it's very like, the baby just slipped off, So you have to be, because you suddenly see that there is a perineal tear, you are just at a shock, how it has occurred. So basically, because there are some 7-8 patients who are delivering at the simultaneously different phases of labor, and I imagine there are 2 patients or 3 patients who are delivering at the same time. So where to go? Whose perineum to save? This patient's perineum or this patient's perineum? So as a registrar or houseman, probably you might have encountered such situations.
Yes, sir.
Now it is a different scenario. Now there are 4 sections waiting, and which section to take first? Whether to take this one or to take that one.
Correct.
So things have changed, and I really appreciate, hats off to all those junior JR1 and JR2. Efficiently they manage the whole labor ward, and ours is a tertiary center where 50% of the deliveries are because of the referred and transferred cases, and vaginal delivery is equal to that of cesarean sections, because they are eclamptics, they are previous to LSAS, they are placenta previa referred or taken electively, or an accidental hemorrhage or an IUFD. So you can imagine the amount of OTs. There are 2 OTs. So these are all smaller logistic things which we come across, and it's really a great time for all of us. So as Dr. Madam has said, these are the different types of perineal tear, and it will depend upon where the tear is. If it is just cutting the vagina first, if it has gone beyond, involve the fascia, the perineum, and all the muscles, then it is 2nd and 3rd degree, where it has cut off the sphincters. So we have got external anal sphincter, internal anal sphincter, depending upon less than 50%, more than 50%, that is 3A, 3B, and if it is both external as well as internal, both are torn, then you are having EAC, and then 4th degree is the worst unfortunate situation, where the anal canal is also ruptured. Apart from this, an anal epithelium is seen. So this is the worst scenario which you can come. Now let us see the technique, madam. I think I'll go back to Dr. Lalwani.
Yes, sir. So usually the 1st degree is only confined to mucosa or skin. 2nd is involving the muscle. So 2nd is nothing but our routine episiotomy which we give. So definitely it has to be a layer technique. So if it's a clean, when we see the incision made episiotomy, if not extended, it's not deepened, we just have to start first with the mucosa. It has to be continuous interlocking suture. We should use Vicryl, or even rapid Vicryl can be used. And then we have to take the muscle. If the muscle is deep, we should make sure that there is no dead space when we are taking the muscle, because there's always a risk of hematoma. Patient can just say that I'm having an urge to defecate, so we have to rush and see. And the 3rd is definitely the skin. So skin closure should be accordingly. We can even give a subcuticular on the skin. If the patient is from the upper standard or socio-demographic, she has a good way to prevent any sepsis in her episiotomy wound. Otherwise, the mattress is always the best. And the suture material is 3-0. And what do you say? When we just take, we have to make sure that the hemostasis is ensured when we are taking the episiotomy. And
So,
for the
yes, sorry,
yes,
madam.
sir. Yes, sir, definitely. And when we sometimes we come across the patients who are referred with, only the mucosal lacerations. There are so many lacerations, so it's always better to give a good exploration. So we just take the patient to OT, sometimes, and then we just explore cervical tears associated and the extension of any tears. So it's always better to just have a good vision, and under the good asepsis, with a good team, we should just keep such patients reserved in OT.
So I think most importantly is that if it is first to second degree, you can how JR1, JR2, or maybe a registrar can manage. But
Yes, sir.
beyond that, should not you need to call a qualified person, because this will be the first time and the last time. You don't want any recurrence, and especially if there is an anal sphincter involved or there are sphincter injuries, I think you should have a qualified person to operate this. You have already said the steps which we need to go ahead and to do this, and the layered method. And there is, crossing over after taking the anal sphincters. You need to cross it over and see that you tie properly, and you have to have a good perineal body and
Reconstruction of perineal body.
Reconstruction. And it can be a subcuticular or a deep sutures. You already said about the suture material. You need to have a very fine delayed absorbable or a early rapid absorbable suture material, so that the strength and the tensile strength is maintained. Yes. And also remember that you do not approximate tight. And that's what you do, because then it becomes too much constriction, because the perineal body is in the center. And it is like any midline, situation. The blood supply is going to be affected in such circumstances. If it is a straight cut down going up till the, the sphincter or the anal canal. If it is an extension of an episiotomy, well, the healing is much more better, and then we can go ahead. So these are all small things. As you said, also we need to have a atraumatic interrupted sutures, because if there is a hematoma, at least it will have a space to come out.
Correct.
Okay. But if you are going to take continuous interlocking and you are going to totally close the muscle, each layer, then it will not have a way to come out. So that is the reason our seniors, or what we have been telling, and you have already said, and I am sure all of you agree in the panel, that it needs to be done in such a way that there are, you start from above, go downwards. If it is an episiotomy, extension, or a perineal tear, also from above, up front, and then go down. And you also need to have a interrupted sutures in layers, so that there is adequate hemostasis. I appreciate your point of stressing on hemostasis, because if that is not maintained, and then all problems can come across. Well, it's very important. If you are going to have an external anal sphincter tear, you need to have a proper hold with a large, long Allis forceps and hold it properly. And then have a long figure of 8 stitch, keep the ends long, cross it, and that's an overlapping technique. So this is or an end-to-end.
End-to-end.
Yeah, end-to-end. So the whole idea is that you need also to, widen and refreshen the whole sphincter, so that you get some leverage of that. And the best method is, I think, I would prefer, is to overlap, so that they are having absolutely tight, and the strength is also regained. And it's very important now, when you are dealing with near the anal canal, you need to have burring sutures which are not exposed into the anal canal. So always put a finger or a little finger inside and check whether, if you are very close to the anal canal and any of those sutures have gone through it.
Not pass. Now we should remove those sutures.
Yes, you have to reopen again, again, madam. And this is the most important technique. Of course, asepsis, changing of gloves, and all this parameters of betadine douche, etc. needs to be done.
The assistant just keep checking, sir. Whenever the assistant can just put her hand in the rectum and keep
Yes.
checking if there is any adverse entrance of the suture material in the anorectal epithelium.
Yes, yes. So I would like to ask now Dr. Jaimala.
Yes, sir.
Now, after doing all these things and everything is going to be great, the way you have done sutured. Well,
Yeah.
now we have already taken consent, explained. Mind you, you are always talking with the patient.
Yes.
I'm sure madam and everyone is already talking because they become anxious. They need to be counseled.
Yes.
They need to be told that there's nothing to worry. But now what about the next delivery? You know,
Yeah, I think that needs to be spoken at this time itself. You can tell her that what had happened. She had a 3rd-degree perineal tear, which is well, sutured. So hopefully she wouldn't have any symptoms. Yeah, you have to tell her regarding avoiding constipation. Give her the general advice, wound care, how douching or whatever. Like you can use betadine solution to clean, antibiotics and all those, and then tell her plans for her next delivery. If she is asymptomatic after all these suturing, say 3 months later, she doesn't have any anal incontinence or fecal incontinence or flatal incontinence, that you could tell her that she can have opt for an elective cesarean for next pregnancy. But on the other hand, we in UK, what we always say is, like, if you are symptomatic, you can have a normal delivery next time and then you can correct it later on. Also, that is an option that you can give her. But if she is well controlled, there's no incontinence, it is better for her to go for an elective cesarean section next time. But again, like,
no, it should be only offered. That's what the literature tells. Only for the 3rd and 4th degree perineal tear. Otherwise, that fear. Because see, even though the scar on the physical scar has been corrected and it has the time has healed it, but the mental scar, the scar in the brain, that trauma, it affects them a lot. And as we are sensitive to their feelings, we need to understand that. If they want to have an option, surely we can go ahead and help them. But we need to tell them that, as you just said now, very important statement, that you should go for a normal delivery. Just do not go for a cesarean section. And unless if the situation arises for any other obstetric indication or probably any other fetal indication, then maybe we can think about it. But not as per se only for a perineal tear, injury. Dr. Dominath, would you like to add something here with your experience?
Yes, actually, they have to be delivered in the hospital. That is this thing, and need not actually for 1st and 2nd degree. So no need for 3rd and 4th degree, sir. We are little skeptical, and we may go ahead with section.
Now, madam, everyone is not so fortunate, and unfortunately this patient comes after suturing also a perineal tear. She still has an anal incontinence. Now what to do? Should you go ahead and repair it immediately? Maybe she's following up.
No.
Say 6 weeks have passed and the best of the best surgical hand has done the surgery, but still she has anal incontinence.
It needs repair, but we have to wait for all the edema, everything to come down, and then delayed repair, sir.
Dr. Lalwani, Dr. Jaimala, sorry.
Anal manometry can be done, to look for what is the pressure, and if there is any disruption in the anal sphincter, can be seen by the endoanal ultrasound. So you can have a look at it, and if it is persistent and if she has symptoms even after 6 months, yes, you can go for, if we are confident enough to repair it, you can repair it or refer her to a colorectal surgeon.
Colorectal surgeon. 6 to 12 months, it might take time for the strength to just come. And in spite of that, if she's symptomatic.
What about Kegels exercise and physiotherapy, whatever like we advise? Is it
may help us a little bit, but not with the disruption after seeing an endoanal ultrasound.
And that also after 6 months, we should better advise for endo-endal ultrasounds to see for the pressures. And otherwise, it's always better. Even after 12 months, if she's coming again and again with persisting symptoms, it's better to refer her to colorectal surgeon.
Okay. So I think there is a general consensus. The first 6-8 weeks, you can still go ahead with physiotherapy, Kegels exercises. But if it doesn't help, then anal ultrasound, endoanal and ultrasound will surely tell us the details further. And then the next surgery, it would be always better to have a multidisciplinary approach and to call a colorectal surgeon, because this will be the last and hopefully the best option should be given to her. So now we move on to the next case. How to prevent a perineal tear. I think this is quite okay. This we can just pass on. Now we come across episiotomy. A patient has been delivered. She has gone through all these things. Her vital parameters are fine. Uterus is fully full term, 4 centimeter dilated. She's on Pitocin drip, and following 5 hours she became fully dilated. Forceps was applied, maternal exhaustion, mediolateral episiotomy was given, and male child 3.2 kg delivered. Well, everything was fine. Uterus was well contracted. However, just put on antibiotic, but on day 3, the episiotomy, which was sutured, was also, gaped up. There was some fever where paracetamol and was given, and there was serosanguinous discharge. You can see the picture also there. There is a episiotomy which is gaped there. Now, what to do next? A very simple thing. We're talking very simple.
So you need to assess what was the degree of the perineal tear. Maybe we have to reassess the situation. It was not just a 2nd degree perineal tear.
This was an episiotomy gape, ma'am.
Gaping of episiotomy. This is episiotomy gaping.
Yeah.
Okay, so assess. If just clean the wound, put her on high dose antibiotics, take wound swab. Yeah. And then you have to keep cleaning the wound. If there's any necrotic tissue or anything, you need to do the wound debridement. But if it is a clean cut wound, it's 3 days. Sometimes I do secondary suturing straight away. After the antibiotics, and if it's a clean cut, I do secondary suturing.
I remember my madam used to tell to apply calendula. Some people had put sugar. They used to put God knows, what things. And now we have got, lot of other things are there. You just put a gauze piece and daily you do dressing.
The granulation tissue comes up.
Maybe acriflavine, insulin, acriflavine. It depends. What is it actually? Because the whole idea is that what is the best option with all these things which we have done?
Secondary.
So we usually immediately we don't suture.
Yes.
We should
wait
for the healthy tissue.
Yeah.
Sometimes
so
it does
small ones they usually heal, actually naturally heal. Very rarely we have done secondary suturing for episiotomy. Practically telling, I have had to very rare.
Exactly.
Most of the time they heal by themselves.
Gaping in perineal tear itself is very rare. We don't see it. But, sometimes when it is healthy also, it gapes. In that case, you can do resuturing. But most of the times, we leave it. By secondary intervention.
Exactly. If it's much deeper.
Giving by secondary intention is the option which is there. Not all will require a secondary suturing, because the stay in the hospital will be for a longer time now, maybe 3-4 days extended. And how would you maintain the perineal hygiene? I remember in those 25-30 years back, they used to have a hot water being put in the bowl.
Betadine, sir, we can advise to the
So
patient.
what was given and what is done nowadays? Like there, what is routinely or in such?
So first of all, the perineal hygiene. Now, if they are applying the pads, sanitary pads, this is also one important thing, because sometimes they just apply cloth or dirty cloth. Sometimes we are in the medical colleges, patient coming from lower socioeconomic strata, so we have to just inculcate, maintain good hygiene. You should wash the area properly, from not back forwards but from forwards to backwards. So that is one thing. Then when
they are supposed to maintain hygiene, hand washing after they go to
hand
the
washing.
when to go to for urination or defecation. or even breastfeeding and, maybe cooking, etc. There are small things where the hygiene has to be maintained.
Correct. And so local, some application, usually some wheat gel. Yeah. Yes, madam.
We just have to keep it clean. We don't apply anything, no other this. Doesn't need much anything, sir.
Just simple
Routine,
water.
we don't.
Yeah.
Clean
Plain
water.
Plain water.
When they are,
wash.
yeah.
If you keep this area clean and one
And
dose
dry.
of antibiotic enough, actually doesn't need anything.
Exactly. So they have to just report if there is any.
We don't even use seed bath and all now. We don't use seed bath,
Yes.
ice, this thing, nothing we do. But they heal.
I think that's very important. Nowadays, we are not going ahead with doing all these things. It's very important to go ahead. Okay, now this is a very rare, unfortunate case where you can see the whole extension of the wound has occurred. As you cannot see because it's all blood covered.
Yes.
You cannot see the internal, beyond the peritoneum because it's blood covered. But unfortunately, this patient was there with us. She was a previous LSCS with IUFD in a transverse lie, and post LSCS day 14, she was with us. And then on 4th day, there was fever, and then distension occurred, and there was soakage of blood, wound with the dressing. On removal of the dressing also, we could find that there was infection and discharge from the wound side. And then because of that, we had the alternate suture removal on day 7. Then day 8, she had, dehiscence. So what is dehiscence actually, madam? Welcome, Dr. Komal. Yeah.
So there is simple dehiscence is just the wound gaping away. But when you tell burst abdomen, it means that even the peritoneum is given away and we are able to see the internal organs like intestines or omentum.
The peritoneum
and something
has
is
given
that is a
away.
burst abdomen.
Yes.
Peritoneum has given
Peritoneum goes away, then it's complete burst. When there is complete
Burst of the
facial
burst of
layer
the-
just give way. Dehiscence usually what sometimes the muscle peritoneum just keeps the bowel, inside the abdominal
When,
cavity.
the rectus has given way. You can see the peritoneum being there, but it has not totally, the intestines
Given
have
way.
come out.
Not coming out, that's partial burst or dehiscence, we can
And
say.
I've seen this in radical Vardine hysterectomy in a vertical
Yes,
midline case on day 7 and 8. I've seen this in my residency days. Nowadays, of course, it's quite rare, but
But still it comes sometimes.
yeah, but sometime it comes, and then you have to be very careful. So, what are the predisposing factors, Dr. Lalwani?
Definitely predisposing factors. First of all, the indication for surgery, like pre-existing factors are definitely there. She is immunocompromised. She is having over diabetic. She is diabetic, anemic, or malnourished, or if there is any indication
Obesity.
for surgery when we are anemic, definitely.
Obesity
And
also.
obesity, we have already discussed, one of the important risk factors. Then the reason for which we are taking her up for any laparotomy or surgery, for that sake, it could be, as you were telling, sir, a case of malignancy like CS cervix or ovarian or endometrial tumor or something. Then if there is any sepsis, sir, already a patient is immunocompromised, like maybe she is in uremia, or whether already there is some kind of, source of sepsis in her. And when we just take her up post-operatively, these patients might just show, at 6th or 7th day, sudden onset of gush of, peritoneal fluid like thing comes out, and we should just raise an alarm. It should just raise an alarm or suspicion of burst. Not if complete, then partial. So some risk factors definitely, and the patient is having a prolonged corticosteroid use. Sometimes in the pre-op workup, we might miss that significant history. And the patient is a known asthmatic, or sometimes increased intra-abdominal pressure, patient is coughing. And one more thing.
Nowadays, we are giving abdominal binders. Can you just add something on that?
Sir, usually abdominal binders are not routinely advised for all the patients. But yes, in the patients, when patient is having, post-operative cough, or sometimes the intra-abdominal pressure is increasing, in those patients, we can actually give them binders after post-operative day 3 or 4, just for that support sake, mechanical support, but not routinely they are practiced in all the patients, I should say. So this is the thing. And again, sir, all the patients, that obviously 1% risk in the literature is there for burst. And yes, midline vertical, the healing is compromised when we are opening by the midline vertical incisions. In such patients, the incidence or the risk of burst is automatically increased, because the approximation of the rectus, the wound, the healing, all these things are compromised when we are opening up vertical. Suppose she's previous 3 cesarean sections, sir, and we have taken her up for again 4th laparotomy or for 4th cesarean or for hysterectomy for that reason. So in such patients, definitely we can go for some binders when they can help us, but not routinely. So the mechanical, how you are closing, sir, one of the important factors I like to highlight, the technique of closure. That is also important. Sometimes we can just do mass closure. So these mass closure in the single layer, that has been shown, a superior against layered closure when we are taking the patient for emergency laparotomy.
Yes. Hello.
So mass closure is, yes, sir.
Yeah, I'm really sorry, because I cannot see Dr. Meenal on my screen, and Dr. Rajeshri, Dr. Banashri. Please contribute. I was under the impression that since I cannot see you here on the screen, I was passing on your questions to the other colleagues. I would request them also to participate in the discussion. Because I cannot see the other participants on the screen. I can just see the slide. So please excuse me. Dr. Meenal, would you like to
Dr. Meenal and Dr. Banashri, you need to just unmute yourself.
Yeah, because I cannot see
the
the video.
videos, ma'am.
I cannot see. Now I saw your video. Yes. I would
Can I
request Rajeshri, Banashri to please unmute or show your video. That's the reason I cannot see. Yes, Meenal, welcome. Meenal is a former student of Sion Hospital. She's practicing herself in Solapur. She has an IVF center and a hospital. And well, she's a very good academician. We would like to request you to please participate in the discussion. Yeah.
Definitely, sir.
Welcome. Yeah. We are discussing about wound gape, wound infection. Meenal, have you seen any wound dehiscence or burst abdomen in
Yes,
your?
sir. In Sion Hospital, when we were residents, I have seen wound dehiscence, and as a residents, we have done daily dressings also for those patients. And I've seen that secondary suturing was done, and later on, it got completely cured also.
So was it a vertical incision or a phalansteal incision? Which
no, it was a phalansteal incision, but the patient was extremely anemic when she came, and the LSCS was done in view of baby factor. Some meconium was there, so
fetal
LSCS
distress.
was yeah, fetal distress.
So I think all those corrections need to be done beforehand, but unfortunately, some patients just land up at your doorstep with a hemoglobin of 4 and 5 grams, and then by the time you're giving her blood transfusion, etc., and then we have to do a cesarean section. I remember in those days also we used to do vertical incision just for fetal distress. 30 years back, 25 to 30 years back, maybe Dr. Kasturi will agree with me. Just because there was a fetal distress and a drop, we used to just open.
No, we can't get in there.
I mean, I used to have, my seniors used to also suggest, Niranjan, oh, you did a vertical incision for fetal distress. So this was about 30 to 35 years back, So there was a very clear cut that there is a clear, if there is a fetal distress, you need to go within 20 seconds and deliver the baby out. So all those things have really stopped now, and we need to go ahead and, go ahead. Dr. Kasturi, with your permission, I can pass this question to Dr. Banashri Batra. Yes. What are the treatment options now?
No problem, sir. No problem.
Yes, yes. Thank you. Thank you, madam. What are the treatment options now if you have a situation of a burst abdomen? Welcome,
So
Dr.
yes, sir. Burst abdomen is an emergency situation, emergency condition. So definitely we have to put a gauze and cover whatever inner materials or bowels have come out, and then we have to rush the patient to emergency OT for repair. So in that case, it usually it is better to go for layered closure under general anesthesia. So it also depends upon the condition, the situation or the hospital where we are working, especially in the government hospitals. It is not very uncommon to get a burst abdomen. I'm not saying that every month we are getting it, but on and off we get burst abdomen. We get to have this. So we are taking these patients and then the closures are being done in an emergency situation, sir. And
now, would you like to take a surgical reference and go ahead with a multidisciplinary approach with the team, or just as a gynecologist? As a
definitely better if we get a surgeon. So actually in government hospital, always we don't get that liberty, but definitely if we get a surgeon, it is better to work with. Definitely it will be better to take a surgeon along with you when you are closing this such type of cases. Sir.
So I remember, taking tension sutures myself, mass closure, like in total whole of the length of the abdominal wall had to be taken, and we used to cut the Malakot's catheter. If you see a simple rubber catheter or a Malakot's catheter, we used to cut them into pieces, and we used to use ethylone. And before the mass closure, we used to put a tension sutures through and through, come out from the other side, and then keep it long and put a rubber tubing, so that once the mass closure is done, we used to put the tension sutures and close with the rubber tubing. I think Dr. Dominath, can you share on, or Dr. You can share your views on this?
Yeah. Yes, usually here, this thing, we do call a surgeon because it's on a safer side. Though we have a surgeon by side, and then we take, as you told, sutures. That's very, very important, so that again it will not cut through or everything. One is that, and then keeping a drain both intra-abdominal and in the wound is really helps, sir, especially intra-abdominal, because any collection, anything, again, this should not give away. So drain is very, very important here, both intra-abdominal as well as superficial drain.
Yes.
Once we had a patient, sir, with a burst, so we took a surgical opinion as well, but actually that was an unhealthy tissue. There was quite a slough and it was a partial burst. So they actually kept that patient, with dressings for a longer time. She was there because she was also having, she was referred from outside. It was a hysterectomy done outside. And then we just discussed with the surgeon that how long can we just keep her like this? So they said, even if it's a partial burst or even if the rectus has gone, there's not emergency to put, but still the tissues are unhealthy, so we can wait. And even if, she goes for secondary intention healing, they can just repair it later when she comes with hernia. So this was the thing where they just, discharged and the patient went well. But it was a long time because it was completely, sir, the necrotic fasciitis kind of a picture. So they just left that wound open for secondary healing. And then maybe she'll come now some months later for hernia repair. So that was their, input, which we just, which made us wiser that day.
That can be done only.
Ma'am, you are not, ma'am. Am I audible? Actually, I think
you're audible. There is some issue about Dr. Donima.
Okay, sir. Okay.
Yes, madam. We understood what you are saying. Yes, madam. Dr. Kasturi.
Yes, sir. If pattern is open, it has to be immediately shifted. It's an emergency. We have to shift to the OT and repair immediately. And better to take a surgeon opinion. Sometimes, if there was peritonitis, we have to rule out any other bowel injury or anything, sir. So taking a surgeon opinion, seeing to that is clear. Only it's better with flow because there was lots of pus inside also sometimes. along with burst abdomen. So
Yeah.
other factors also have to be ruled out. So better
Yeah,
to take a
because
surgical.
exactly. Sometimes some collections are there, madam. Intraperitoneal, some hematomas,
Yes.
broad ligament hematomas, some any, some collection. So all these things have to be simultaneously drained, or intraperitoneal
Yes.
have to be kept, and
So
then closure.
it's not only about treating the burst abdomen or a dehiscence, you need to also, since you're gone and now you would like to again check the hemostasis, that's what you are trying to say, or remove the pus or remove some hemoperitoneum if there is a collection, not always.
Not always. Just a collection,
Not
sir.
always.
Sometimes patient has this picture, there is
The case to case.
Okay.
Yes, madam.
Yes, sir. Individual patient.
Individualization would have to be taken into
Yes.
consideration because you have an ultrasound report which tells you beforehand. You take if you have an ultrasound report, but if it is a clear-cut infective case, then you need to also think about giving a peritoneal wash.
Correct.
So
Yes,
it
sir.
will all be individualized, and if it is related to some hemorrhage, secondary hemorrhage because of infection which has led to some hematoma or some sutures which have given way, you might have to also see the lower uterine segment, the scar, the integrity of the lower uterine suture line, because
Sometimes it's connected.
yeah, it is
Sometimes it's
connected.
giving way through that. It's
Yes.
connected. The
And
track
there
is
will be
there.
pus also in the uterine cavity or the lower uterine segment incision which has been taken. It has given way. There are some gaps of 2 to 3 centimeters. So all these things you will have to do a proper assessment, and an
Exploration.
individualization judgment will have to be done. Just do not just close the
Exactly.
abdominal wall with mass closure and tension sutures and come out, because you never know what is kept there inside. I want to ask a question to Dr. Banashri. Now, once you have just managed this, any other way of closure which you have experienced? Now, like once you have done a proper only mass closure has to be done, or you need to do a layer closure. What are the suture material would you like to take? Would you like to take Vicryl, or maybe something like monocryl or something?
Sir, usually we are using Vicryl because in our place, monocryl in our hospital supply it is not there. So we are using Vicryl only. But for the skin, obviously non-absorbable sutures are being used, and along with it, the tension sutures are also used. And as you said, sir, the drain, putting a drain is definitely an option. We should think of it, because there may be a hematoma, there may be a collection there later on. So for that, we definitely have to keep a drain there. And always it is not that the mass suture can be done. If we require layer suture is also, there is two school of thought. Some are saying that you go for a mass suture, but it is seen that if we are doing that interrupted sutures, so I have seen the surgeons also doing these interrupted sutures. So we can go for that also, sir.
One thing I'll just like to just share. Sometimes, sir, we have to mobilize the rectus sheath, because
Yes.
after some 10 days, 12 days, it's just one complete edge. So we have to just exactly. So if it is possible, it's always better to mobilize the rectus sheath by giving a good dissection. The plane has to be made between the rectus sheath and the muscle. We have to make sure that all that necrotic, the edges are freshened as far as possible, so that the healing and approximation is better. So in that case, if we are able to get the good edges of rectus sheath with the good angles, we can just take, usually we take with Prolene, sir. So with the Prolene, we just close the rectus, and then the skin we take in a single, then we don't take, separately other layers. We take the skin with Ethilone.
Yeah, I do agree. I think it is better if you take either delayed absorbable PDS or Prolene rather than Vicryl in this
Exactly,
situation.
because it's a resuturing. What even I think we have to give a good, strengthening of the rectus sheath is very, very important.
Yes, Dr. Jaimala, would you like to share something? Like if there is a gross wound infection, well, the skin has been open and you leave it open, put a pack inside if there is some bleeding, and then go again. You
So
know,
actually, I'm a private practitioner where I didn't see any burst abdomen since 1997 when I was an intern. So actually, I don't have any experience in managing burst abdomen. So I mean, leave alone. We don't even.
anyone can share their experience about, you know, packing with some mop or some towel inside and then coming out again and then resuturing
No,
something
I
like.
think people
No.
use this negative pressure, whatever this wound vac. They use this, right? For
That is for drain.
Drain.
What sir is trying to say, sometimes it happens that the bowels have come out and they are so much distended that at that point of time it is difficult to close or oppose the abdomen. So
Like
in that,
Dr. Lalwani just said that she needs to mobilize the rectus muscle and the rectus sheath individually because the closure doesn't occur. It's very easy to say that you do a mass closure and close it. Even if you close and you try to approximate them, the edges do not come close to each other.
Exactly.
Because the distension has occurred, there probably is an infection, there could be an ascites, whatever the reason, or a hemoperitoneum which is coming out, and the bowels are quite inflamed and distended. So you need to think about something different also.
So in rare cases, this may happen that we are unable.
Sometimes the surgeon's mesh can be put by the surgeon, sir. If there is a very
infection
for the rectus.
Sorry for interfering. It's already 7:26. I think we need to just wind up.
Just 4 minutes now. 4 minutes. The discussion is at the pinnacle of its, it's not only theoretical, but this point needs to be covered. We are ending the case now. Yeah. So I think that's very important. A mesh, you need to mobilize the rectus sheath, and then we need to also think about all these possibilities because, of course, post-operative management is a very important thing. A care of a respiratory system, cardiovascular system needs to be done, and then we need to pack. So it is better to open and see than to wait and see. This is by Sydney Cuthbert Wallace, and as suggested by now, we are at the end of it. Thank you so much. But what are the take-home messages? Just one line from each one of you, all expert. Kindly unmute yourself, Dr. Chitgupkar, Dr. Banashri, and others who are there, as I can't see their faces. Yes. And of course, Danta, you can also, you are an assistant professor in AIIMS Kalyani. You can also surely contribute in this discussion, just being Dr. Anisha, you can hear me, right? You
Yes, sir.
Just let's start from Dr. Anisha, one-liner.
So we should try to give our best to the mother so that even if there is problem, we should be able to deliver. Like each obstetrician and gynecologist should be able to send back a healthy mother and healthy baby back to the home, whatever had been her postnatal period, whatever had been complications.
So as to avoid any medico-legal complication. That is the most important thing. Yes. And being beaten up. Next.
Proper case selection and thorough pre-operative preparation is mandatory.
So another thing is that infection can be avoided if proper hygiene is taught to the patient. Like someone said that while cleaning, it should be from front to back and not from back to front. This is a very basic thing which many patients don't know, and they bring about the infection. So teaching, especially those patients we are dealing who are coming from rural India, should be taught about the perilian hygienes so that they are able to deal with such, to prevent such infections.
The one thing which I just like to, my take home and I want to highlight is that we should not run behind antibiotics. I've seen post-operatively for cesarean sections, primary, uneventful, they are giving for 3 days, 4 days, IV lines, and it's infection. You guys, it's always what I personally feel is how meticulously, how like you are giving her a preparation, scrubs, how you are actually taking your scrubs, all these things. During OT also, the technique which you are using, how you are, approximating the skin and all those overzealous mattress, sometimes the JRs will just do, overzealous tightening. And then because you are doing overzealous tightening, there will be no blood circulation and they just open up. And they say, हमने तो mattress लगाया था, पता नहीं कैसे खोल गया. Even the subcutes, they don't open up so easily because if the technique is good. So I personally think, और उसके बाद dressing कर रहे हैं, फिर betadine से और ये. So 48 hours, you should just give a good one, एक betadine or spirit से just keep it open in air, well ventilated.
Okay,
So,
ma'am, thank you. Now we go to Dr. Jaimala.
Yes, sir.
Your
Yeah,
one
that's
liner.
what, yeah, that's what I said. You said a proper case selection and proper pre-operative management is very important. And as Dr. Suman said, yeah, proper techniques, surgical techniques, that is very, very important. Like, yeah, not over tightening, what suture material you use, perfect hemostasis, no over cautery, and then, yeah, subcuticular stitches. And if the subcutaneous layer is more than 2 centimeters, I would say I would close the subcutaneous plane also. And yeah, after post-operative management, yes, I discharge my patients within 48 hours. So we leave it open after 24 hours.
Yes.
And we don't see any problem.
Good bath after 48 hours, she can just apply good soap water in the stitches. They usually don't take bath for 7 days and they come with secondary infection.
Dr. Rajeshri, please, would you like to say something?
Yeah. Good evening, sir. I have been listening to the wonderful conversation which was going on. Since I am in the labor room and I was not able to switch on my video, I had requested Komal that I'll be listening to the talk. And all that has been summed up so far regarding the care of the wound and everything. Not to forget the basic of the surgical principles that we all have to keep in mind, that diligently we need to respect the tissues and meticulously and religiously follow each of the steps and protocols which are necessary.
Respect.
And that is one of the basic basic.
Everyone is doing Narasimha technique. Everyone wants to. They are in Narasimha.
No, definitely not, because even as on today with 25 years of practice, I still close all the layers of the abdominal wall.
Yourself,
including
the end of the surgery.
myself, especially in the private practice and also in the institute where I am the head and dean research of the university. I make sure that I stand there to see that everyone is trained well so far as the technique. And before we make our residents and interns or anybody do the technique, we have to be conscious enough to teach them at least 10 supervised closure of the wound, at least 10 cases before we hand over to do them independently. And that I feel is the basic, because nowadays in the given scenario of antibiotics, the blood transfusions and the case selection scenarios, and not unlike before wherein there used to be a prolonged obstructed labor before the patient reaches the hospital. We don't have such case scenarios now. We have mostly the patients who reach the hospital with the 108s and etc. Much early, and especially in Karnataka, I can say that the outreach program has been very good and the referrals have been quite early, and it's very rare that we find a burst abdomen. I have not seen one burst abdomen in the past 15 years or so. So, and as mentioned by you, the tension closure and all we were doing as postgraduate students, we have seen in the government hospitals and setups wherein the patients were anemic, debilitated, hypertension, unattended, unsterile conditions, sepsis, blown up sepsis and all such scenarios. But now, when we meticulously follow the surgical principles, make sure of the hemostasis and diligently, follow the principles of surgical techniques, such scenarios can be avoided. And most importantly, the bleeders which are there, not to ignore them, and hemostasis adequately maintained, just not to write in the notes, but then definitely make sure that you maintain the hemostasis very well before you do the surgical closure. And that I think is very, very important for all of us to follow as surgeons, because in obstetrics, we have only 2.5 surgeries. And if we cannot do justice to 2.5 surgeries, then definitely we wouldn't have done a good job. We have a cesarean, we have a hysterectomy and a tubectomy, and that's about it, unless we go in for laparoscopy, etc. So it is very, very easy to master the skill and very, very easy to respect the tissues, provided we have that extra 5 to 10 minutes of patience to see that everything and all the job is done very meticulously. Thank you so much.
Thank you, madam. One liner from Dr. Meenal Chidgupkar.
Thank you, sir. Thank you, sir. It was a wonderful webinar and very basics. Actually, for a few minutes, I was in my surgery, so I could not attend. but definitely with sir's guidance and the Sion Hospital, our mentors, teachers, we have actually seen so many cases of wound problems, wound gape, but with meticulous treatment later on, we have done the secondary suturings and things are done. So prior, when it is not emergency surgery, we have to first understand what is the hemoglobin status of the patient. And during doing the procedure also, we have to be meticulous, and we have to give certain times after delivery of the baby prior injectables and complete suturing, complete all layers we should suture. And then when we do all surgeries meticulously, definitely there will be zero infection rate. Thank you.
Thank you. Thank you. Dr. Kasturi.
Yes, sir.
Tony Math, your last word, then I hand over the mic to Dr. Komal.
Okay. Yes, sir. Actually, it was a very excellent discussion, and everybody has covered it, so I'll not repeat it, sir. Only strict aseptic precautions prior to surgery, intra-op, and perfect hemostasis, and will go a long way in preventing all these complications. And no use of excess suture materials. We should not. Our suture materials use also should be less, because more foreign body reaction and more the problems. So that also, if we take it, and all other points have been covered. But I'm very happy that this topic was taken up in this panel discussion. Very rarely discussed, because we have panel discussion on so many topics. But this wound infection, I was feeling it had taken a back seat. Thank you, Dr. Komal and Dr. Chavan sir, for taking up this topic. Very new topic and a very practical day-to-day topic. But it is not discussed topic.
Sure.
So very, very happy that when they told wound infection, I thought, oh, day-to-day we come. So it will be like a more practical, our own ground reality problems we'll be discussing. So thank you so much for this, and thank you for involving us. And all the best to Dr. Komal. Looking forward for your great results.
Victory.
Victory. Yes.
Thank you so much, madam. I think thank you everybody, all the panelists. I think your words were so concluding remarks were so good that we need to be good with the tissues and handle it, and the suturing techniques and the suture material all play a role. And we really wanted to discuss, because it is the most practical topic, and we really don't want any problem in the wound. How much ever effortlessly or tiringly you do the surgery for hours, but ultimately patient is going to go with that wound on the abdomen, and we have to do our best to give her a nice wound. And that was the idea that we said we should discuss this topic, because it is of interest to so many people. And thank you, Dr. Niranjan, for moderating it so well. And to all the panelists, Dr. Kasturi Madam, Dr. Jayamala, then Dr. Astha Lalwani, Dr. Yeah, your name is different. Yeah,
I could not change. That's my mistake.
Yeah, Rajeshri Palladi and Dr. I think Meenal just I think she off her video. So Dr. Meenal Chiplukar and everybody who joined. I think it was a lovely, enriching session and panel discussion. Thank you, Anisha, for being the coordinator. Lovely work done. So with all that, we conclude our episode W. And
thank you, ma'am. Thank you so much, ma'am. Thank you, ma'am, for giving me this platform. Thank you, sir.
Yes, thank you so much, and thank you all for your wishes and support. They mean a lot, and we will definitely have elections from 1st of August. So do remember to vote. Pass on the message to your friends and colleagues, because that your word will definitely make a difference. And see you next episode in the next week. Thank you so much.
All the best. All the best. All the best.
Nice.